Hello, a very good morning in Europe and America, a very good afternoon in Asia, and probably a good night close to there about in America. Thank you very much for joining us at Ifso Apc, day 2 of the session. We welcome all the participants, all the speakers to this session, the 28th of November. I would like to introduce my co-panelist on the session of revisional surgery and weight regain. I have with me my co-panelist is Dr. Tejana. Dr. Tejana hails from Sri Lanka. Tejana, we were supposed to meet you and do the conference in Colombo this time, and unfortunately, because of COVID, we are here. So thank you very much, and we look forward to your great contribution. My second co-panelist today is Dr. Eduardo Oliveros, who comes from Philippines, and hopefully soon we'll be seeing this conference in Philippines as well. It is indeed my great pleasure. I will introduce the first speaker, and then subsequently Dr. Tejana and Dr. Eduardo will introduce the subsequent speakers. We will have Dr. Sutep, who will go first today. Dr. Sutep hails from Thailand, a very well-known figure in the Asia Pac region, commands a great bariatric center in Bangkok, a great friend, and does a lot of work in the area of revisional surgery in Thailand and Asia. Tejana, would you like to introduce Mufi?
Yes. So, Dr. Mufazal Lakdawal, or we fondly call as Mufi, is no stranger to the IFSO world. So, basically, he's one of the top 10 bariatric surgeons in the world. Actually, the current Guinness record holder for operating on the highest weight person on earth. So, Mufi has been a great inspiration for IFSO and also the IFSO APC, especially in bringing up the bariatric surgery to the difficult areas and in even like smaller countries like Sri Lanka. He has been a great help and personally visiting and tutoring and so on and so forth. He's considered as an expert in many areas of bariatric surgery. So without saying too much, I will let the next speaker be introduced.
Dr. Eduardo, would you kindly help us introduce Dr. John Dixon before we start the talks?
Okay. Hi, good afternoon. Yeah, I'm pleased to welcome Dr. John Dixon here to our conference. He's from Australia. Melbourne, is that correct, Dr. John? Professor John? Okay, he's from Melbourne. Asim, he didn't give me very much to. I didn't get his. I didn't get Professor Dixon's CV prior to this, but he's a renowned expert in bariatric and metabolic surgery. He's done so much research in this field of surgery and countless, and they're all peer-reviewed and really well documented research works. Professor Dixon has worked with many famous surgeons in Australia, like Professor Paul O'Brien. He's one of the great pioneers in bariatric surgery in Australia. Aside from that, Professor Dixon is a great speaker, and we're honored to have him in the Ifso Apc.
Well, thank you very much for those kind introductions, Tejana and Dr. Oliveros. And we will now start moving on to the actual talk. The first talk is going to be by Dr. Mufasal Lakdawala today. We will start our session with definition of weight regain and indication of revisional surgery. The first talk will be by Dr. Sutep, followed by Mufazal Lakdawala on complications of revisional surgery and drugs versus surgery in weight regain. Thank you very much.
Good morning, dear Ifso friends. This is Dr. Sutep Udom Swangsap from Jula BMI, Department of Surgery Refractive Medicine, Chulalongkorn University, Bangkok, Thailand. And I'm going to be talking on definition of weight regain and the indication for revisional surgery. Thank you for the invitation. For weight loss after bariatric surgery, if I'm putting, for example, the study from Phil Shower, for the lower BMI, you will see that comparing medical treatment versus surgical treatment, so you will see that at 12 months will be the lowest of weight, and after that the BMI will be increasing a bit year by year, and the curve will be flattened during the third, fourth, and the fifth years. I share to you another study, the randomized control trial between sleeve gastrectomy and lumbal gastric bypass or SMBOS, with the initial BMI of 35 to 55. Same phenomenon has been shown after first year. The curve seems to be increasing slightly for both bypass and sleeve gastrectomy, but anyway, it's still keep a good result afterward. This is another study to show the durability of weight loss for long-term result on adjustable gastric banding sleeve gastrectomy and lumbal gastric bypass. After first year, the curve seems to be increasing a little bit, and the result will be different according to procedure types. So we have to define the weight regain. It could be the weight, any weight regain after the nadir phase. It could be increasing more than 10 kilo from the nadir. It could be any increasing of more than 15% of weight. But it could be increasing of the BMI of 5 kilo per square meter from the nadir. Or weight regain to BMI more than 35. Or an increasing of weight more than 25% of excess weight loss from nadir. So there are several definitions. This study to show the association between definition of long-term weight regain and the clinical outcome at a 5-year study of lumbal gastric bypass and sleeve gastrectomy. This is the definition of weight regain. And the clinical outcome of type 2 diabetes, hypertension, dyslipidemia, or the arthrosis. What they found was only the definition of more than 10 kilo or the weight regain back to 35 would be associated with the OSA clinical outcome. So another study to compare the weight regain after surgery and the clinical outcome, or define the relationship between weight regain and the progression of diabetes, hyperlipidemia, hypertension, and the declines in physical and mental health related quality of life. This BC table will be showing those results. But anyway, if we have a look closely into the progression of diabetes, what they found was that the regain more than 10 kilogram or more than 5 BMI point, the regain more than 10% of pre-surgery weight would be related to the progression of diabetes, as well as the more than 20 or 25% of maximal weight loss, also showing the relation to the progression of diabetes. So if we use this definition, you will see that at 3 years, what we found that 30 to 50% of those who have bypass would be having the clinically important of weight regain, or if we have a look on 5 years, we'll see that 40 to 60 to 70% would be categorized into this group. Coming back to this study and having a look on the weight regain and the decrease on physical health related quality of life, you see that any of the definition will be showing significantly the deterioration of the physical health related quality of life. If you have a look on all clinical parameters, the percentage of maximum weight loss more than 20 or 25% will be very much associated with all clinical outcome. So it's hard to have a consensus on the definition of weight regain, but anyway, at some point of the treatment, the patient may need the revisional surgery. So let's have a look on the indication. If we look at the indication, it could be the inadequate weight loss or weight regain or the complication. How can we define the inadequate weight loss and weight regain? So we have to have the point of the success. So those who have never been into the success would be inadequate weight loss. And this, if it was a first study to show the clinical outcome after gastric bypass to define the success, and it correlate with the absolute body weight and general health. And you can see that if it's more than 200 of ideal body weight, it will be a failure. A success will be defined as the patient could be going to not more than 150% of ideal body weight. And it would be excellent if the patient could be at 120% of the ideal body weight. So from this study, the success would be the patient can do more than 50% of the excess weight loss. This is what we have been using for a long time. And also another study, the result of the surgical treatment of obesity, the prospective randomized controlled trial comparing VBG and gastric bypass. So this study had shown the success was defined at BMI less than 35 because it's the mortality risk increasing rapidly at this degree of obesity. So this is also the point of the definition of the success. So the indication of the revisional surgery, if it's the inadequate weight loss, will be defined as those who have less than 50% of excess weight loss, or the BMI never been below 35, or those with weight regain that we have been discussing already. Last would be the complication. So from some study, you will see that mostly will be coming from weight regain and following by complication. So the indication for revisional surgery, it could be lovely saying that for those who have the body mass index or the comorbidity, those are qualifying for the bariatric surgery. So depending on each guideline from each society, but at least 24 months following the primary procedure. So this is the generally accepted the indication for revisional surgery. It's very complex, and it need to be very carefully taking care of this group of patients when they are looking for the revision. So the dietitian consultation, psychiatric evaluation must be involved, surgeon consultation, and the several tests needs to be done. The upper endoscopy as well as the fluoroscopy have to be tested, and multidisciplinary team should be involved. The patient must be under the conferences, and the multimodality of treatment need to be applied at least 3 to 6 months for weight loss. It seem to be re-evaluated and re-intervention with non-surgical treatment until the weight loss have been shown, and that would be the point that the patient would be um, scheduled for the revisional surgery. So it's very important for the multidisciplinary team to be taking care of this group of patients. So ladies and gentlemen, my conclusion from the definition of weight regain and indication for the revisional surgery would be there's still no consensus on definition of the weight regain, but there are several accepted definition that's being used. And what we have found was that the weight regain does affect the metabolic result directly. And there is no guideline for the indication for revisional surgery. It's very important for the multidisciplinary approaches to be taking care of this specific group of patients. With that, thank you for your attention, and I hope to see all of you soon in the future. Thank you.
Hello, everybody, and it is strange that we meet in such strange circumstances, but hello to the entire bariatric surgery brotherhood from Asia Pacific. Congratulations to Manuela, Stefania, and Kazoo and the entire team to still manage to pull this off. And really, I'm very, very proud you guys have done it. So today we're going to speak on revisional surgery, and I'm supposed to speak on the complications and challenges that revisional surgery present. As we all do know that as the numbers of bariatric surgery keep going up in the world, the number of revisional surgeries will go up as well. The highest number of revisional surgeries happen to be in North America, of coursingly, because the maximum number of procedures happen in North America, but in Europe as well. And the lowest number of revisional surgeries, surprisingly, are in Latin America, less than 1% of all the cases. But probably, I think we'll need more tabulation to get this done. Now, as we do know that the reason for revisional surgery is multifound, right? So the more procedures we do, the more revisional surgery we get. So the trend is that gone are the times of the VSGs and the LGBs. And as we do see that the procedures, which are the standard procedures, you will get some form of revision. Because I believe that bariatric surgery per se is a procedure which, if done on a younger patient, not done properly, or done on a super obese patient, will need revisional surgery at some point of time. So just by the nature of the procedure, it will need a lot of revisions. Now, the reasons for revisional surgery, as we all do know, is weight. And the very fact that we are doing these surgeries for weight, unless we're talking about metabolic surgery in the low BMI, where we're talking only about diabetes remission, most of bariatric surgeries are done for weight and weight-related issues. So the definite reason for revisional surgery has to be weight regain. Complications are 26%, and of course, both complications as well as weight regain and comorbidity inadequate revision. So if you were to do a systematic review of the definitions of failure in bariatric surgery, the big problem about revisional bariatric surgery per se is that we don't have one definition of how do we define success. So first we need to have parameters to define success. Initially, we used to count excess BMI loss, excess weight loss as your criteria for success. But for any excess BMI or excess weight loss, you took an arbit definition of standard body weight for an individual. Now, we do know that that completely changes from a muscular man to a not so muscular individual. And therefore, we've gone away from this very concept of excess body weight loss. And now we are all talking about total body weight loss. So most of the publications we spoke about, less than 50% of excess body weight loss, are now almost redundant in today's scenario. Now, this is the nomenclature that came out from the American Society for Bariatric and Metabolic Surgery. So what they defined is that revisional surgery per se had to be divided into three categories. One was conversion, procedures that change from an index procedure to a different type of procedure. All right. So let's say if you were to, the older concept of only restrictive procedures to malabsorptive procedures. Now, we've gone away from that concept, but the conversion was for those kind of index procedures. Now, corrective procedures, so procedures addressing a complication or incomplete treatment effect of a previous bariatric operation. So for example, if you've got a complication out of a procedure, let's say you've got reflux after sleeve gastrectomy, or you've got dumping syndrome after a Roux-en-Y gastric bypass, or you've got malabsorption after a DS or a BPD, then these procedures come in. Then it comes to reversal. Now, reversal or restoration of original anatomy usually happens in those procedures which are reversible procedures. For example, a Roux-en-Y gastric bypass, OAGB, a mini gastric bypass, which was, or probably any procedure which needs a sleeve gastrectomy where we remove the entire stomach. Of course, this doesn't hold good. So these are the obsolete bariatric procedures, and they needed conversion. So from the JIBs to the BBGs to the non-adjustable gastric bypasses, all of them have been changed. The JIBs for severe diarrhea, electrolyte disturbances, protein energy malnutrition, acute liver disease, and renal disease, or that. So these are the complications with these procedures. BBG from weight gain to staple line disruption to pouch and stomas to soft gallery, and stenosis at the obstruction site. Non-adjustable gastric bypass, intractable vomiting, pouch dilatation, food intolerance, erosion and slippage, and high failure rate. So all these causes were the cause of failure for these procedures. Well, we've all seen these, and today the American Society has advised all those patients who've got GIB to get it reversed. These are the commonly performed bariatric procedures today. And what do we need to do? The indication of revision, like I said, would be one of these various things. But the big problem is that when we go into revision, you will realize that there is a high mortality rate for all those patients, and these mortality rates are higher than those for primary bariatric procedures. So you cannot jump into any bariatric procedure just straight up. So you have to be very careful, because you must remember the morbidity and mortality of any bariatric procedures, especially when it is revisional, is far higher than that of a primary bariatric procedure. Now, what are the difficulties with any revision surgery? Well, you must understand that if a patient's not lost weight or regained a lot of the weight, then the patient's psychology or morale might be to be blamed. Because of the failure of a primary bariatric procedure, did you do the procedure correctly or did you do it wrong? What is the choice of revision procedure that you have to choose for a particular procedure? Let's say you were to do a revision surgery and the patient still does not benefit from it. That's what you need to take into account. And whether it has to be done concomitantly or at an interval stage. For example, a band removal and then converting it to either a sleeve or a bypass or various other procedures. You must remember that every revisional procedure will be technically difficult because the anatomy will be obscured and you need a superior skill set to define that. There is a much longer duration of stay. So for any bariatric procedure, before you operate on a patient, a systematic review of the reasons for surgery medical weight loss outcomes need to be. So a complete psychological evaluation has to be done for this patient. Now, again, because of the complications, it is very, very important that we use easier approaches, things like endoluminal revision of procedures like tightening of the stoma or pouch narrowing or various other. Now there are tightening of the sleeve with the newer devices which are available. So all these endoscopic procedures give us a much lesser morbidity and definitely a much lesser chance for mortality before we do these procedures. Remember that leaks, then DVTs because of a longer surgery times, various other complications such as bleeding, sepsis, pulmonary complications, all are accompanied with bariatric surgery revision, and therefore you have to be careful. If you are doing a procedure which lasts much longer, then rhabdomyolysis might be a significant complication that you might have to deal with. So in view of all these, you have to be very careful that you choose the right option. Now, what one must know is that when you're choosing revisional procedures, the failure of any primary procedure is one of the most serious issues faced by common bariatric surgeons today. So let's do the procedure correctly to begin with so that we don't land up with these problems. Because once the complications happen, then it's a completely muddy scenario. We need to have well-trained surgeons to perform revisional surgery, and you don't need a novice who's doing the first surgery to go out and try and attempt a revisional surgery. He has to have a senior person around. There is still a lack of consensus of the criteria of failure. So let's define our criteria for success so that we define which bariatric surgery procedure has to be done. Now, surgeons must know that surgery should always be the last option when, and then which procedure to be done and when it has to be done should be known before you advise revision, because the complications are far higher. And the role of counseling becomes of paramount importance here. Now, these procedures carry a much higher risk of complications as compared to the primary bariatric surgery, and therefore must be done at high volume centers with experience. Remember that sepsis, leaks, DVT, pulmonary embolisms, and rhabdomyolysis remain the primary cornerstone of complications of any revisional procedure. So please remember all these various things before you attempt to do any revisional procedure. Thank you so much for patient listening, and I hope we can meet in normal circumstances when the scourge of this COVID disappears. Until then, stay safe, brothers, and see you all very soon. Thank you again.
Hi, it's John Dixon here. It's a pleasure to be with you at this virtual meeting. I'm going to talk about, in the session on revisional surgery and weight regain, drugs versus surgery. These are my conflicts. You'll see that I have conflicts with surgical, medical, and dietary treatments to manage obesity. Anything that works, I'm conflicted. Now, when we look at the weight loss with our various procedures, you can see in this figure here that the gastric bypass, the adjustable GAN, the biliopancreatic diversion, the sleeve gastrectomy have average weight losses for a community. The standard deviation is very large, about 8. And you can actually have a look down here at the 95% confidence interval for, say, gastric bypass. It can be 13% weight loss and up to 43%. For bands, 3 to 33, for biliopancreatic diversion, etc. What we find, though, is that, that if we're not achieving 20% weight loss, there's going to be 15% of the bypasses, 55% of the bands, and 2.5%, as we can see. So, in fact, some people, even if we use the standard deviation of 8, which is only present early on, we will see an enormous variation in outcomes. And it's important when we see that, because we can't predict in advance how our patients are going to do. So we've got normal expected outcomes, but we have a problem with expecting above average results from everyone. Not understanding what's normal and expected is problematic. And having an unreasonable view of surgical efficacy and a low threshold to reoperate generates a large revisional workload. And we know that a revisional surgery is associated with greater surgical difficulty and risk. There's limited evidence that interventions help, and certainly many don't help. And we've got to consider for the patient, first do no harm, and consider the issues of those patients who've in fact lost a lot of weight prior to their surgery. Remember, they are working from a higher level than when you first did the surgery, and that's what they're regulating around. So what has been your heaviest weight is important. When we look at weight regain, we really do need to, first of all, not blame the patient. We need to look at the type of surgery and say, is there something wrong with the surgery? Now, this is perhaps the easiest thing to do, and it's the easiest concept that we have to fix. But we also, so whether it's whatever procedure, we know the kind of things we need to look for. Is there another cause for excessive weight regain? And we can look at things such as psychological conditions, medical conditions, psychotropic drugs, etc., and functional changes in the person's life that have led to this problem, or may have led to this problem. So we need a transdisciplinary approach to the biopsychosocial and nutritional issues that this patient may have to explain what might have happened. Remember that our weight is regulated, as are all other essentials for life, by the brain. We are treating a dysregulation that's driven by early life experiences within the brain. Our patients should never be blamed for the problem. And we can see here that bariatric surgery with the Sweets Obese subject study produces, all the procedures produce prolonged sustained weight loss. They are changing that regulation, but not everyone has regulation changed in the same way. Not every type 2 diabetic has excellent glucose control, or every hypertensive has excellent hypertension control. So what are the options now for managing these people? Well, first of all, if there's a clear surgical problem, a problem that can be addressed with the bands, a leaking system or band erosion, gastroesophageal reflux, a gastrogastric fistula with a gastric bypass, etc. But we also have to think that they are not the common problems we see. And options now involve weight management, lifestyle interventions. Remember that all of our excellent treatments, whether they're drugs, surgery, or very low energy diets, actually enable lifestyle to actually work for a change. If your management doesn't include meal replacements, very low energy diets, pharmacotherapy, and all of the accepted surgical programs, it's incomplete. It fails to offer effective therapy that's proven. We have to use the whole range of effective therapies if we're truly going to manage these patients holistically. If we look at weight maintenance after intensive weight loss, dietary weight loss, we see that drugs, meal replacements are the best ways of doing it. High protein diets, but look at their exercise or dietary supplements. No value at all. Important to recognize that. So interventions such as very low calorie diets, which are the sort of high end of meal replacements, and drugs are useful. And this work by Tom Wadden, medication, this was actually done years ago, sibutramine, medication and behavioural modification, behavioural modification, and meal replacements. So think about these patients. We can do very well. When it comes to drugs, there are a couple of reviews that have been done on drugs, very few formal interventions. But we'll see here that in this review done by our American colleagues, that topiramate alone seemed to be one of the few drugs that worked, and phentermine was working. At least it increased the chance of someone having 15% or more weight loss. Orlistat, there's a study down the bottom there, does produce better weight loss than using the placebo, 8 kilograms versus 3 kilograms. Useful interventions. The only drugs that actually work, topiramate, yes, and individually phentermine partly, but of course the best combination that we have today, and we'll have better in the future, the best combination we have today is those two drugs put together. So this is a review from Canada, 13 studies. This is a pharmacological treatment for patients post-bariatric surgery to improve the weight loss. Most of them were retrospective case series, etc. Most notably, phentermine and topiramate as monotherapy or in combination seem to provide the best results. There are limited data on liraglutide, and much of it was the diabetes dose of 1.8, not 3.0. All patients, all studies actually show that the vast majority of patients achieve weight loss, and on average there was significant weight loss. The results of the systematic review suggest that that as an adjunct to diet and physical activity, weight loss in bariatric surgical patients will be helped. They also found that the complications associated with the drugs were very similar to a non-surgical population. These are the drugs that we have available today. I've got lorcaserin blocked out. We can have phentermine and topiramate together, or over on this other side here, phentermine and topiramate separately. We've also got liraglutide, which is in Saxenda, a 3 milligram form, and naltrexone, bupropion, and of course orlistat, which has been around a long time. All of these can be used carefully with regard to post-bariatric surgery. Importantly, we always use drugs. Unlike surgery, we can give a person a trial of drug and remove them if it's not working. We find that we use a stopping rule. If someone hasn't had a good effect with a drug, or a good at least 5% weight loss with a drug, we'll tend to stop it within 3 to 4 months of the maximal dose. We also, of course, stop it if there's adverse effects. So, for instance, responders to both naltrexone, bupropion, phentermine, topiramate, and liraglutide, if they're responders, they will actually achieve 11%, or in the case of phentermine, topiramate, even more weight loss. So drugs can produce very significant changes and add to your surgery. Drugs will only work if they're taken over the long term. This is just the data on how phentermine and topiramate work together to produce that effective connexia. So just also to let you know that semaglutide seems to be a bit of a game changer in pharmacotherapy. It's a GLP-1 agonist similar to liraglutide, but it produces about double the weight loss. And there were many cases, studies of this presented at the Obesity Week in the US last week, another virtual meeting. We also have a string of future targets for drug therapy, and I'm very positive about the use of drugs into the future. So what we're seeing is that drugs, surgery, and the third pillar to our arm are very low energy diets. 800 kilocalories is less than 800 kilocalories. These are low carbohydrate, they produce ketosis, they're very effective indeed, and they're proven. If you're not using them, you've got to think about them. Of course, we see them as a state of the art for shrinking the liver before surgery. This study shows how they can actually act over 2 years, and this was 2 groups looking at how they can reintroduce these from time to time to maintain weight loss, and they did very well. Two methods, but you'll see they produced really significant weight loss on top of the lifestyle interventions. And of course, you'll all be aware of the direct study from Mike Lean and the group in the UK, showing the remarkable changes with very low calorie diets and its effect on remission of type 2 diabetes. Shown results very similar with the weight loss, 86% remission of these patients with 15% or more weight loss. So we have therapeutic inertia when treating obesity. Bariatric metabolic surgery and devices, less than 1% uptake globally. Meal replacements, 0 in some countries, but in those that use them, probably less than 2. Pharmacotherapy, less than 2%. Why are we not treating obesity? Stigma, blame. It's their fault. They should do it themselves. So my message is, if your weight management service does not provide all three approaches, have a major rethink. Think about what your program's missing. Why is it so? It's not surgery or medicine, or not surgery, special diets or medicine. It's blending these together to treat the patient and grade up treatment as necessary. Thank you. Remember, surgical therapy is not a contraindication to other therapies. Medical therapy is not a contraindication to other therapies, and knee replacements are not a contraindication to other therapies. Thank you.
Thank you very much. Can I get my panelists back online here? Thank you, Eduardo. Thank you, John. Can I have Mufi? Well, thank you. That was really an enlightening session. Great talks. Thank you, John. Thank you, Mufi. Thank you, Sutep. Manuela, would you like to launch the poll while we have this discussion going on around? And I will urge all the participants, if you want to ask a question, there is a chat box around here. Please put in your questions and we will attend to your questions. So first of all, do we have Sutep around? Mufi. Mufi,
Yes.
thank you. That was a really great talk. Thank you for taking up that real great talk. On the basically indications for revision surgery and the complications around revisional surgery, if there is one advice outside this lecture that you would want to give the young surgeons, those who are seasoned, what would that be with regards to procedures for revisional surgery?
All I'd like to say is, so you see these advertisements which experts perform, and you feel that you can do it yourself. Please be very careful. Remember that you will get your chance and time to do your revisional surgeries, but be very, very careful. There's a higher chance you'll burn yourselves and your hands with it. So do the first procedure correctly always, and take your time before deciding on which revisional procedure to do. All of us have learned our lessons the hard way. We don't want you all to relearn the wheel. So please take advice from some of the seniors and some of the people who've been around, and choose surgery as a revisional procedure for complications, of coursingly, but for weight gain or weight regain or inadequate weight loss or for metabolic remissions, choose it with very, very, very careful consideration. Look at all other options before surgery.
Thank you. Tejna and Oliveros, we've had the poll questions, and you can see in case of a failed adjustable band, what your choice of a revisional surgery would be. Would you guys like to comment on this as moderators, co-moderators, and Mufi will take your input, just one-liners, please.
Can we see the
panel?
Yeah. So yes, sleeve gastrectomy is a fairly decent choice for a failed gastric band. But the problem is that's also a restrictive operation, and the failed gastric band itself has been a restrictive operation. So I personally would think a bypass is a better option in that particular instance. And the other thing is on a banded stomach, a sleeve will have a higher chance of leak. This has been proven over and over again. So for that reason, I think a bypass is a better option than a sleeve in a failed gastric band. I think that's what I have thought. Yeah.
Thank you, Oliveros.
Yeah, thank you. Well, I'm not surprised the sleeve gastrectomy was chosen over the gastric bypass. My opinion is I would prefer a bypass actually, rather than the sleeve. But for the younger surgeons nowadays, they probably would prefer to do the sleeve over the bypass. It's a lot easier, a lot less stress. So I'm not surprised that was the choice by most common choice chosen in the poll.
So,
of course,
Oliveros, what would you like to tell? What message would you like to give to those people who are converting bands to sleeve in terms of technicality?
Okay, for me, I would go on what is your experience first. If you're more experienced in doing a sleeve, then go for it. But if you think the for me, if the gastric bypass is a better surgery than the sleeve, then do it. If you have to call for help, as Dr. Mufi said, just bring in somebody who has more experience with you to give the proper surgery. If the first surgery wasn't good enough, the second surgery is more important. So call for help if you need to do the bypass.
Thank you. Mufi, your take on it.
Yeah, I think that choose the right procedure. Remember that you would need to do an endoscopy for all cases before you redo a surgery for a band. Look at the kind of hiatal anatomy, look at the kind of reflux the patient has got. Remember that sleeve per se is a refluxogenic operation. So be careful before you were to convert it to a sleeve, because reflux will persist. You might have issues with it. Gastric bypass in terms of weight loss is adequate enough if you were to do longer biliopancreatic lifts. It depends on what reason you're doing it for, but please investigate thoroughly before you're going in for a procedure.
Thank you. John, I'll just take that opportunity.
I just want to say a couple of things.
Yeah, please.
One, that we should never use the word failure in our patients with any treatment in any chronic disease. They have a poor response or they have complication. We can remove it, we can change things, but failure is such a damning word for our patients who are suffering from clinically severe obesity. They don't like the word, and surgery doesn't fail. They have a poor response to it, and they can have a poor response to diabetes, drugs, etc. You can have a poor response to anything, and I think we've got to just accept this. So we have extraordinary results with some of our things. If you look at Walter Poyer's original data from his group of patients with diabetes, he got 49% excess weight loss on average at 10 years. That means 51% of his people failed using these efforts. What we're trying to do is improve the health of these people, and we shouldn't be using these temporary ideas about what is excessive weight regain and so forth. It's sustained weight loss that has the effect. And if you look at that direct study that I presented to you and the work in the New England Journal recently from Sam Klein's group and a whole string of other studies, the whole idea of beyond weight loss is totally questionable. The effects on diabetes are identical whether you use a very low calorie diet to get the weight loss as with gastric bypass. So we've got to be very careful that we understand what we're doing and how our treatment's working. The idea of restriction and malabsorption are just rubbish in how our surgery actually works. So until we understand the disease properly, understand that we're trying to get a combination of therapies that work for a particular patient, I think we're very naive thinking that one surgery's got this superiority of another. And I love the way you were talking about it, Mufi, talking about the reflux with a band or reflux with a sleeve, and thinking about the patient, not necessarily about what's going to give me the biggest and best bang for my bucks in weight loss, because we've got multiple ways of trying to get that, and we'll have more and more of these alternatives in the future. So I just think we've got to think of the disease and the patient rather than as much weight loss as we can get. And we can't cure diabetes. We can't cure any of the complications of obesity. We can't cure obesity. We're treating it as a chronic disease.
Thank you, John. So, John, do you think then there should be an international effort? Like, we've come up with the Edmonton obesity scoring system, which takes not only in account BMIs, but disease at stage of disease. We should revisit this at bigger conferences and properly iron out how do we define success and poor success and excellent success.
Yeah, we don't do this for diabetes. We look at the glycemic control. We look separately at hypertension. We look separately, and we look at the quality of life. We look at the complications that they're having with their treatment, hypoglycemia and so forth. We take a more sophisticated look than a binary success or failure or average. We've got to start to think about those broad outcomes. And we had a wonderful meeting a few years ago, Mufi will remember it, and that we all attended. I can't remember where it was, Chennai or one of the meetings we had with the with the Indian group, where the experienced people from around the world in surgery came together and said, look, we've got to really think carefully about these patients. Well, you'll remember it, the meeting we had, and I think we really got together and said, look, we don't understand the physiology of what we're doing very well at all. There are a lot of questions to be asked, and many of our revisional procedures, you've explained it, Murphy, the increased risks, the increased complications, and so forth, and the often poor outcomes. So we need a more sophisticated approach, and I think we do need to bring the medical people, the surgical people, the psychological people together to really discuss the patients, and that's why I like the transdisciplinary approach. This is an epidemic, a chronic epidemic, a bit like COVID. Look at the experience that's coming together to solve COVID at the moment. We need that sort of impetus to really put bariatric surgery in its proper place, operate on more people, but not reoperate on huge numbers because they don't quite get to a certain level. Different approach.
Thank you. That was really nice. Sutep, welcome to the crowd. Sutep, thank you. Sutep, how do you view weight regain as we would define it? And how do you counsel your patients? What parameters do you take into account before advising patients for another weight loss surgery? As we said, it's a chronic disease, and we're just talking about weight here. We're not talking about medical problems and anything. And say somebody who was 60 BMI went down to 40, is now 47. What are the few things that you would like to tell the younger people that before you really do this, what do you need to think? Can we brief that in half a minute or so, please? Sutep, I'm afraid I think you're muted. You may have to unmute yourself.
Okay.
Yeah, lovely. Thank you.
Yeah. Good evening, everyone. I'm sorry for being late, but still in another commitment. But very nice to see all of you here. So for the question, yeah, you said not talking about metabolic or other diseases, so which we need to be taking in account too. But for weight, I think, as I'm shown from the study, that it's been still no consensus or what should we do for the determination or definition of success, or when it will call, we need to consider for the next procedure. But anyway, the principle is that if we use any definition to categorize the patient to those who may need for another treatment or additional treatment, I think the multidisciplinary team, I'm sure that we've been already discussing about this part, need to be taking care for the patient very much before getting into another, especially for the surgical treatment, but medical treatment as well as the lifestyle modification, diet control need to be, get into the treatment at least for, I would say, 6 months. After that, it need to be, taking the multidisciplinary need to be involved, and that's what the most important part of what we gonna go for the next procedure. But I agree with John that we should, explain, not only limit to the weight, but yes, for our bariatric surgery or metabolic surgery, we are taking care of the diseases. So we need to, think for those parts that we need to be going to. But anyway, at this point, practically, yes, we need to have the multidisciplinary team to be taking care. Thank you.
Thank you. Tejana, I think there's a question on the board. Tejana, you want to please present the question? I think there is a question for Professor Dixon. So,
where do you see the role of a pharmacist in the preoperative or longitudinal care of the patients? I assume these are the patients who have regained weight. So this question is to Professor Dixon, asking about the role of the pharmacist in care of management of the patient with weight regain.
I think we're talking about pharmacists. We're talking to the people who who disperse drugs. I think pharmacists have a key role in our community, as do general practitioners. They're the people that our patients see very regularly. They're the people who we need to educate about our effective treatments, and they should be able to give people trust them. They're the most trusted people in our communities, the pharmacists and GPs, the people who are in primary care. And if we can get them to understand our treatments, the surgery, the special diets and so forth, and the drugs, we will be able to bring many more people along and treat many more people effectively. So I see mixing these things together, educating pharmacists, educating GPs, educating nurses broadly, you know, people who are working in primary care, that we can treat this chronic disease. We're getting better at it. We can't cure it, but we can treat it very well. And the stunning results that we see from metabolic bariatric surgery across the board, without necessarily all the best weight loss, they're really, really good. We've got great treatments. We're going to have more great treatments. We're going to refine our surgery, refine our drugs, refine our meal replacements. But we should be treating people. At the moment, we're just not treating them. So pharmacists, primary care, GPs need to learn about all of the things we do to help our patients and become involved and see it. You know, there's nothing like seeing someone who's had great success with weight loss to actually get referrals. They want that thing, and we shouldn't be damning any of our treatments ever, because they all work. I hear people say, I don't believe in very low calorie diets. Well, that's fine, but they work. I don't believe in drugs. Only surgery works. I don't believe in surgery. It's dangerous. It's this, it's that. We have to be enthusiastic about all treatments and get our societies to join us in treating this chronic disease. So it's a really important thing for us to be advocates and really advocate for better treatment across the board. And please be very careful you don't damn any treatment that works. It's very easy to.
Can I follow up that question with Dr. Dixon regarding the drug therapy, if you don't mind, Professor Dixon? What's your opinion on using liraglutide 3 milligrams for post-bariatric surgery weight regain? You think it's the most promising drug right now?
What we don't know. One thing I can tell you is that the drugs we have, we've got about 5 different combinations or drugs, preparations that we can use. It's a bit like trying to treat diabetes in the 70s, okay? 50 years ago. We don't have a great deal of choice. We might say that bariatric surgery has come a long way since the 1980s. It has. Safety, efficacy, etc. So we're moving along in a continuum, but we are at a very basic stage. We need to, because we've got so few drugs and because there's got specific issues associated with them, we need to try and match the drug to the patient. And one of the ones commonly used in the United States is Contrave, the naltrexone bupropion. I know a lot of people use topiramate alone. A lot of them use combinations, and Saxenda's being used, the liraglutide's being used more and more. The problem often is price, because and cost, and liraglutide's probably the most expensive in most countries, very expensive in some. The bupropion, the Contrave, or there's other names for it around the world. The Contrave is next. It's still quite expensive. And topiramate and phentermine are dirt cheap, and they've been around, typically dirt cheap, and they've been around a long time. They're all equally effective, but they've all got their indications, contraindications. So I think we just should be brave enough to use them, and remember that semaglutide is going to be a game changer. It really will, I think, be able to treat a lot of people who really don't respond well to whatever surgery you've given people at the start. So something that can produce on average, a 15% weight loss is something that is so much better than almost any other treatment other than surgery. Even all of those gastrointestinal things that we thinking about and we want to encourage, and remember, don't damn anything. It might be there important for a group of people, but we need to be able to treat the majority of our patients, if properly, with effective therapy. So don't damn any treatments, but I think semaglutide will be the one I'm looking forward to in the future, and we're going to have that available shortly. And I'm hoping that it's not at a price like liraglutide was when it came on board.
Well, thank you. Mufi, just 30 seconds, words of wisdom for surgeons before we end the session. Mufi, I think you're muted, please.
Okay. Hello, everybody, and words of wisdom. Let's not make the same mistakes that we've made in COVID, wherein every expert had an opinion to give out of there, and very soon realized that nothing seemed to work. So in bariatric surgery, let's, like John said, let's not be 100% sure that this is going to cause weight loss because my procedure is the best. Let's always say that we'll have to work as a team with drugs on one hand, which have got the least probably given side effects as compared to, let's talk with our endoscopy colleagues whether they have a better solution on board for that. And finally, let's talk to our seniors and colleagues and ask them whether something that they've tried in the past has worked for them or not. And then finally, depend on yourself. So depend on all these people before you depend on yourself for revisional surgery. Thank you so much.
Thank you. Oliveros, over to you for the final closing remarks. Oliveros, you also muted, sorry.
I'm sorry, that's a bad habit of all of us. But I'd like to thank everybody for listening to today's session. And for one, as Professor Dixon said a while ago, don't blame the surgery. Look first at the patient and what they've done wrong. It could be other things. So for the younger surgeons, don't immediately jump to another surgery, which can be very difficult. And sometimes with the complications, it could be disastrous. And last thing among all, it can be a financial nightmare. Okay.
Tejana, any last remarks from your side?
Yes, having listened to all these experts, it's quite clear that jumping into resurgery is almost always not the first option in weight regain or kind of surgical failure. Always we should get the nutritionist involved and try to adjust the diet as much as possible, try to adjust the lifestyle and get the endocrinologist help and try the pharmacotherapy, because revisional surgery per se in most instances doesn't guarantee an adequate weight loss on a patient who has had a successful bariatric surgery in the first place. So this is proven, and I think that multidisciplinary approach is much more important than just jumping the gun into another operation. Over to you, Asif. Yeah.
Thank you very much. I think one take-home message is multidisciplinary team, revisit it, go back to chronic disease lessons. Do not go sway away from all these important lessons we have learned. What remains to do is to thank Sutep, Mufi, and John for their excellent lectures, for their expert opinions. Thank you very much. To thank the Secretariat of Ifso Apc for doing a wonderful job. To the participants, thank you for joining us. And I hope the session had been a little bit of use to you. Thank you, everybody. Thank you to the panelists, and thank you to my co-moderators for the session. Thank you very much. Have a great evening.
Thank you, Austin, for sticking to the time.
Thank you. Thanks, our team.
Thank you.
Thank you.
Ladies and gentlemen, please take your seat. Next session is going to start. The moderator can introduce the session.
Hold on a minute. All right, Malfobi here. Charles, are you with us? Okay, he's going to join us in a minute. At this time, we'll have Dr. Chobe and Dr. Heitan with us. And our session is going to be talking about East meets West. So since we are working on a timetable, I think we'll go ahead and probably start the session. And we'll wait for Dr. Murphy. Oh, there he is. You guys caught up. Hello, Murphy. Unmute yourself. Charles?
Yeah, I'm here. Can you hear me?
Okay, yes, I want to make sure you're on.
Yeah, I'm in.
Hi, man. Yeah, finally
Okay.
I've been able to unmute myself.
I
Hello,
know
everybody.
you just finished another session. Go ahead.
Hello, and it's great to have all of you here. It's a strange world. We are all meeting virtually and all in the confines. Dr. Chobe is looking very, very apt as if he's doing a real life presentation, but that's how he always does. So great to see you, Peng, Charles, Chun, and Mal. Thanks for being part of this session. I think Professor Chobe is going to be the first speaker. So I'll go ahead and introduce him. Well, Professor Chobe needs no introduction, has been a past president of Ifso, has been one of the founder presidents of Ifso Apc as well, and one of the architects of setting this up in the first place. He's had so many national awards. He's been a very, very prestigious award in India, which is the Padma Shri, honored by the government for his exemplary work in what he's done. He's been a record holder in the Limpa Book of Records. And I think the more I say about him, the smaller and smaller I look. So I'll go ahead and let Professor Chobe take place, and please go ahead and give your lecture, Professor Chobe.
Thank you very much, Mufi. It's a great honor and a pleasure. Again, delighted to have you with all. Even if it is virtual, at least it is better than not meeting at all. And thank you very much for that introduction. I'm good to present. I think we can go ahead with the presentation. Thank you very much. Hello, everyone. I bring greetings from New Delhi, India, for all of you, and my best wishes. I have been given the responsibility of talking about how East is different from the West, as well as the bariatric and metabolic surgery is concerned. As you know, Asia is a large subcontinent. Almost about 60% of the population is in Asia. And if you really see, India is in the eastern part and southeast part. And that's how, you know, the subcontinent, which I'm going to concentrate here, because there's quite a bit of difference between South Asia and other part of Asia also. So my talk will be mostly related with the subcontinent: India, Pakistan, Afghanistan, Sri Lanka, Nepal, Bhutan, and the related areas. Now, as we know that it is expected that in 2045, the Asian countries will be one of the very, very most, I would say, affected countries in the world with metabolic syndrome and other associated problems with diabetes. And the color itself indicates that one of the biggest sort of, you know, jump in this situation will be from Asia. As you know, almost about 84% rise is expected in this, as compared to the Middle East, which is also will show a jump of 110%. If we really look at the other aspects, we will find that there are a lot of undiagnosed cases of diabetes and metabolic syndrome. And in some of the assessment, we feel and think that it is almost half of the population is undiagnosed. If you really see the mortality in millions, if you see, this is the area which has got a very high mortality, because maybe the undiagnosed patients who are not getting a treatment, At the same time, the medical facilities which may be limited or less facilities which are available in some of the part of the Southeast Asia. So we have got a very, very high mortality as recorded in 2017. With the changing medical care, it might reduce over a period of time. But what is also alarming is the low-income countries will have more morbidity and mortality in times to come. Half of these 4 million people who are shown here are under the age of 60. And this is a very important point which I would like to emphasize, that in this subcontinent, most of the patients who are suffering from diabetes and also having the morbidity and mortalities are less than 60 years of age. That indicates that it is the younger population in the subcontinent which is suffering from this metabolic problem, as compared to the Western world, where we see more and more patients after the age of 60. Also, I think, it's a phenotype of South Asian obesity. High body fat contents. Even at a normal BMI, we observe and we documented that we have got a low muscle mass, we have got abdominal obesity, which is a visceral obesity, and we all know that visceral obesity is metabolically active obesity and atherogenic obesity, and that causes the metabolic syndrome. And also we have noticed increased hepatic fat, and that is the fatty liver incidence is very high here. Type 2 diabetes is really highest. If you really look at the Bangladeshis, even in United Kingdom or any other countries where this population has moved, maybe from India, Pakistan, yet their type 2 diabetes risks are high as compared to the local population. That means there is a genetic phenotype which is responsible for this particular situation. So I think, why does it happen? I think it's very difficult to explain. There are some ways to explain it. We don't really know whether they are true and how true you are. But I think I would just touch few points of the explanation which could be there. And it all starts with birth and early life, when the child is born, and that continues from childhood to early adulthood, and of course in adult life it is already there. If you really see at birth, if you see the thing on the fat content of the Western baby, you will see a lesser fat content. If you really see the Asian baby, you will find that at birth the Asian baby will have high fat content as compared to the muscle mass, which so they are prone right from the birth about this. When we move on to the childhood and early adulthood, the same thing continues, and you know that visceral fat continues to become bigger and bigger. And also we have noticed that there is an excessive subcutaneous truncal fat, which is, again, as we know, that large metabolically active adipocytes which are seen in the subcutaneous fat, which may also contribute to the visceral fat. This is a hypothesis, as we see that truncal subcutaneous obesity is also metabolically active in these patients with the visceral obesity. Now, another situation is the adipose tissue compartment. The fat in the lower limb is supposed to be healthy fat in the lower limb, but it also helps, the fat in the limbs also helps for the oxidation and fatty acid utilization, which is missing from the other locations. Coming to the adult population, of course, the same continuity of truncal subcutaneous fat and subcutaneous fat in the legs, which is less, because I think by and large, more and more Westerners are into outdoor activities. for that matter. And I think the lesser activities are seen in the Asian region, and that is also responsible for the insulin resistance. Because most of the time, I think this is, though I'm presenting it here, but I know that the present generation, the future generation is becoming more and more conscious about it, and we are trying to sort of, be outdoor during the leisure hours rather than indoor. Maybe weather also has got sometimes to play, because outside it's very hot, the temperatures touching 40, 45, and maybe above that also may be responsible for more of a indoor comfortable activities. So I think, insulin resistance is basically evolutionary in the Asia Pacific region, because it depends on the muscle mass, which is less, and if the muscle mass is more, I think, we will have less of these resistance. Another important point is that what type of food which we see. Now, this is not that everybody will have this type of food every day or every time, but I'm just saying the varieties of the food which is available, and at a time for lunch or dinner, we are not restricting it to one food, but I think it's a small amount of so many other food items which are available. So chapati is there, the bread is there, then few types of vegetables, lentils, few types of sweets, etc. is there. So this is also very important. And social perception, of course, it goes without saying that, because this population has starved a couple of decades and centuries back, being a fat has become, is a social perception that if you're fat, then possibly you are good looking, or you belong to a good family, which can sort of afford a good sort of food. This in adult life, I'm sure it continues. But what is specific about Asia, where I would like to highlight, is the fat in the liver. I think we, as compared to any other population, there's more fatty liver patients which are seen in the subcontinent, and we know that it is the cycle of insulin resistance which is responsible, and fat plays a very, very important role in a fatty liver. So at a cellular level also, we see the mitochondria, which is, less, it requires less energy, and hence more energy is converted. And this is what happens, adenoprolactin, leptin, and CRP, which are the responsible for adipose tissue. And this is what the common liver which we see in the laparoscopy. You can see the fatty liver, you see the nodular liver as compared to the softer liver which you see. And I'm sure metabolic rate is also the same. As I said, we have a lower metabolic rate but high incidence of metabolic syndrome. Pancreatic function, also beta cells, genetically is less in number in Asian population. Maybe that produces lesser insulin. And of course, we all read about the environmental pollutants. Strong, strong air pollution can give rise to insulin resistance, which has been documented, and it's known as a persistent organic pollutants which are there. And this is what our newspaper also says, that the diabetes and pollution linked says type 2 diabetes. This is a Chinese study which has appeared. So bad air, high sugar, this is what is responsible. I would like to conclude here that we have got a genetic disadvantage. We, in any case, have got a fewer beta cells, and beta cells get exhausted early. The energy conservation metabolism, which is a genetic disadvantage to all of us. And of course, the growing economy and influence gives us more spare money for the food outside, the junk food, etc., which is more freely available. And sedentary lifestyle, which is there, maybe more seen this time during the pandemic. So thank you very much for your attention, and I wish you all good health and best. Please take care of your health, especially during the pandemic period. Thank you very much.
Good morning, everybody. This is Chun Hai. I'm from Singapore. Thank you to Professor Kasama and the organizing committee for your kind invitation to speak at this Ifso Apc Virtual Congress. Today, I'll be talking about DVT prevention in Asian bariatric patients. So in this, I have no conflict of interest to declare. This is my case mix disclosure, mainly sleeve, some bypass, and some revision. This is the place where I work in, Khoo Teck Hospital in Singapore. Now, the outline of my talk today, I'll be talking about background, the importance of VTE in bariatric surgery, and how Asian data is a bit different from the Western data. I'll come into with some guidelines, ASMBS updated position statement 2013, as well as the CHEST 9th edition ACCP guidelines in 2012. Then I'll go through a risk assessment model. I believe there are a few out there. I will concentrate on the Caprini score, and I'll share with you our hospital protocol and our data from our audit, and followed by conclusion. Now, patients undergoing bariatric surgery are at moderate to high risk of venous thromboembolism. Now, why is VTE important in bariatric surgery? It is because of its sequelae: pulmonary embolism, post-thrombotic syndrome, pulmonary hypertension, and this all leads to an increased length of stay in the hospital, increased economic costs and total costs for the patient, as well as for the hospital as well. And it is the most common preventable death in the hospital setting. Now, incidence in DVT in general surgery itself, according to CHEST ACCP guidelines, is up to 24%. Now, background risk for surgical patients: because of Burkow's triad, we have stasis. The patient is immobilized during surgery and early part of post-op. There is some form of endothelial injury, the trauma, or some form of placement of catheters, and hypercoagulability factors. Now, I'll go into details about the additional VTE risk factors and some of the primary hypercoagulable states. Now, what are the additional VTE risk factors? Now, BMI more than 50, the super obese category, increased age more than 60, patients with congestive heart failure, malignancy, immobilization, trauma, use of hormonal replacement therapy, and oral contraceptive pill, pregnancy, immobilization, paraplegia, inflammatory bowel disease, as well as some form of syndromes. Now, hypercoagulable states include antiphospholipid syndrome, anticardiolipin, protein C, protein S, and this list goes on. Now, just quickly talk about Asian versus Western data of VTE. Now, we have a lot of Western data on VTE, not much on Asian. Asian, I'll present some of you, but they're not specifically related to bariatric data. Now, the Asian data, VTE rates: Korean 13.8 per 100,000, Taiwan 15.9 per 100,000, and Hong Kong close to about 20 per 100,000. Now, rates of surgical DVT rates include 0.15 to 1.35%, and this is about 10 to 20% of those levels recorded in the Western countries. Now, this study separates different ethnicity groups and risk of DVT, PE, and VTE. Now, you can see the highlighted red boxes shows the European rates of VTE, about 115 per 100,000, and Asian ethnicity is 13 per 100,000. Now, this is about 10% of what happens in the Western population. Now, this is from Singapore. Asian population post-surgical DVT incidence 3 to 19%, and Caucasian about double that, 6 to 35%. Now, DVT and surgery in Singapore, incidence 7%. The rate of PE 0.49%, with 1/5 of that mortality. Now, DVT and colorectal surgery in Singapore, this is Asian data. DVT incidence 4.7%, And another randomized control trial that we did, DVT incidence 3% versus 0% if we give enoxaparin during the surgery. DVT and general surgical patients in Asia, just published 2015. This is a systemic review, shows that the risk of VT in Asian general surgical population is low. DVT and orthopedic surgery, now this is post-hip surgery, incidence 9.7%. Now another paper showing an incidence of 7.7% with 0% PE. Total knee replacement, Asian data as well, after orthopedic surgery, incidence 14%. And if you give DVT prophylaxis, that comes down to close to 0%. Now, obesity and DVT, obese patient, higher incidence. Non-obese patient, lower incidence, but no statistical difference. Now, I've shown you incidence of DVT in Asians, but they are not related to bariatric surgery. Now, what's the best we have? Paper by Pravin Raj from India. This is a survey on trends of bariatric surgery, and this is calling for need for consensus guidelines for DVT prophylaxis in Asian obese patient undergoing bariatric surgery. Now I'll talk about guidelines as well. ASMBS 2013 updated position statement, as well as CHEST ACCP guidelines. Now there are many risk assessment model. Caprini score, I will talk about Caprini score. And I understand there's this MBSC scoring system, another scoring system from Cleveland Clinic, and the Bariatric scoring system. Now ASMBS updated position statement states that bariatric patients are at moderate to high risk of VTE events. High risk factors, as we discussed earlier, there's a need to adhere to protocol, and that can decrease but not eliminate VTE. Now, mechanical prophylaxis is recommended. Early ambulation, as well as combination with chemoprophylaxis, should be based on clinical judgment and risk of bleeding as necessary. The low medical weight heparin is better than unfractionated heparin. And post-discharge, we should consider extended VTE prophylaxis for very high-risk patients. The IVC filters is not recommended. Now, maybe I can just comment, this is non-Asian data as well. Now, let's talk about CHEST ACCP guidelines. Rate of incidence of general surgery, DVT 24%, PE 1.6%. And this is non-Asian data as well. Okay, low molecular weight heparin significantly reduce the risk of symptomatic VTE by close to 80%, and prophylactic anticoagulants can reduce the risk of silent DVT by 30 to 70%. Now let's talk about Caprini score. Caprini score, risk of bleeding. So what we have to decide is actually bleeding risk versus the risk of VTE. Now, bleeding risk is actually for GS patients is actually quite low, less than 5%. Now, this Caprini scoring system puts them at 0.1, 0.2, and how many points to what risk factors they are. Now, let's talk about bariatric surgery itself. You can see here at age 41 to 60, we have 1 point, another 1 point for obesity. So all bariatric patients will have at least 1 point here. And if you're older, you have 61 to 74, you have 2 points, as well as major surgery, 45 minutes major surgery, as well as laparoscopic surgery for 45 minutes. Then you have 2 points, 2 points, plus another 2 points. Minimum, you have at least 5 to 6 points. Now we look at the scoring system. The risk level is 5 or 6 points and above is high risk with an incidence of DVT 40 to 80%. And they recommend enoxaparin, either a BD dose or a reduced dose according to creatinine clearance. Now, these other people looked at whether your BMI is more than 40 or less than 40, and whether 40 milligrams of enoxaparin is required, whether it's once a day, twice a day, and whether we should titrate according to BMI. The higher your BMI, the higher your dose that you should give. Now, enoxaparin thromboprophylaxis in bypass patient, and how they measure the anti-factor 10 activity. So this is 223 bypass patients with enoxaparin 40 milligram every 12 hours versus 60 milligram every 12 hours. And find that a VTE rate of 0.45%, and they achieved the anti-factor 10 concentration in 74%. Now, this is our own hospital, Kulipot Hospital in Singapore. An audit of our patients shows that in a series of 416 patients, we have a rate of PE of 0.24%. We don't routinely screen for DVTs, so I'm not able to provide you with that number. So our protocol includes a 40 milligram of subcutaneous on induction and with mechanical calf compression during the surgery. And if your BMI is more than 50, we'll give a 60 milligram of Clexane, and this is also with calf compression. Adherence is 100%. There's only my boss, Dr. Anton Cheng, myself, and my team. So we adhere to this all the time. On the night of the operation, there's early ambulation. We'll make sure that the patient walk to the toilet, and they are usually discharged on post-op day 1 or 2. And we will give extended chemoprophylaxis only for high-risk patients with previous DVT or PE before. Now, I'd like to conclude. The incidence of DVT and PE in Asians are definitely lower than that of Western population, but this rate is increasing over time. Now, there's established VTE prophylaxis guidelines in perioperative bariatric and metabolic surgery. We do follow the guidelines, and whether these guidelines are applicable to our Asian population. So there's a need for a consensus statement by us for VT prophylaxis with respect to bariatric surgery, and I'm working with my team on this so that we can provide some form of answers to everybody. The bariatric patients are at high risk of VTE, and we should combine chemoprophylaxis together with mechanical prophylaxis. Now, extended chemoprophylaxis only for high-risk patients, and it's also very important to have our own hospital data so that we know what is our data and how we can audit and further improve on our protocol. Thank you.
Hello, everybody. Good evening. I'm Dr. Wei Jie from Taiwan. I'm happy to have the meeting including me. So my talk today is diabetes and other metabolic disorder. So I will start from a case sharing. This is a typical case of diabetes in Asia. He's 21 years old male. I already have a good family, but he had diabetes for 5 years, even used the insulin. You can see it's still fully controlled, A1C 10.3, and the BMI is 27.1. However, the waist is quite big, and he already have the urine protein. So, and C-peptide is not very high. So, what is this character with the Western population? So I will cover BMI and adiposity, surgical procedure, and outcome. As we all know, the diabetes incidence increase with along the BMI. However, the BMI 24 in Asia equal to the risk in BMI 30 in Caucasian. So the Asian are more risk on type 2 diabetes. However, if we look the direct head-to-head comparison, the Asian and the Western, on the 11 randomized trial, investigator surgical versus medical treatment for type 2 diabetes, there's only one study recruit both the Asian and the Western population. It is DSS study. It starts from 2007, recruit 120 patients, 60 in each arm. They recruit a BMI 30 to 35 with fully controlled diabetes patient. And in this study, we can see the report. The first report is 2013. The last is 2018. And to our interesting is to comparison the patient from Asia, Taiwan, and the Western American. You can see under the same inclusion criteria from 3 hospitals in America, 2 hospitals in Taiwan, we recruit 30 patients versus 41 patients. The Asian patient tend to be younger, low BMI, short duration of diabetes, less medication. especially the insulin usage is only in 1/3 of the patient. Why the Asian patient have the younger? Because we have about 20% young onset diabetes specific for the Asian. And also there's a high incidence of the renal complication for this group of patient. So if you are poorly controlled young onset, you have an incidence of 4% every year to have end-stage renal disease. Plus 20 years, that means 80% of the patient will have end-stage renal disease. So the character of Asian is low BMI, but higher central obesity, young onset, less Medicaid, high renal complication, short duration for surgery. So this is in accordance with the previous report. Not only diabetes, for other metabolic disorder like hypertension, you can see the risk for BMI 24 is the same risk as the Western population in BMI 30. So it's the similar situation as diabetes. We are more prone to have the medical complication at the low BMI. So now current indication for surgery is for 27.5 for an Asian, but is it not appropriate? I don't think so. So let's see about a surgical procedure. In low BMI patient, we had a proof in a randomized trial. The bypass surgery had a better result than the sleeve gastrectomy. If you want to use sleeve in a low BMI patient, the only thing important is you must have a good C-peptide, that is beta cell function. So if more than 6, you have almost 100% remission rate at 1 year. But if less than 3, there's a very low remission rate at one year. And for the long-term follow-up, we can see the importance of ABCD score for this. You can see the 1 year remission rate and the 5-year remission here is along with the ABCD score. The higher, the better. And as well as the recurrence. If you have a lower ABCD score, you have a very high recurrence rate at 5 years. Another important thing is weight loss. In sleeve gastrectomy, if you want to have a diabetes remission, you need at least have 20% weight loss at the long term. Otherwise, the remission rate is very low. So the efficacy of sleeve is all along with the weight loss. And quite interesting is in this recently published paper, you can see for mini gastric bypass, one of the most gastric bypass, even at the inadequate weight loss of less than 20%, still have some patients can have a long-term diabetes remission. That implicates there might be a weight independent effect for bypass rather than sleeve gastrectomy. So let's see the outcome. Yes, for this gentleman, we provided a precision metabolic surgery. So that is a long sleeve gastric tube with a loop bypass osmosis. We bypass around 30% of the whole bowel and keep at least 400 centimeter common channel. So that is BP bypass 250, common channel is 550 centimeter. And just 5 months after surgery, you can see the BMI drop to 22.7, and the diabetes go into remission, and the renal complication becomes subside. So this is a very promising result by precision metabolic surgery, even for young onset diabetes patient. And talk about a previous study. Actually, at the 2 years, we can see the Asian population from Taiwan had a better diabetes remission than the Western population from America. But we do a multivariate analysis. There's no difference between the nationality. The only difference is depends on the C-peptide. That can be reflected to the beta cell function or ABC score as well. However, do we really bring the good solid outcome for this group of diabetes patients? We have a very good study from SOS, but unfortunately, all of them are the Western population. So they have a decrease of the mortality. However, this is a cardiovascular decrease on mortality, but we really don't have the data in Asian population. This is a recent study from Cleveland. Again, they're showing metabolic surgery can reduce the cardiovascular mortality about half. Hazard ratio is 0.59. Although we don't have a solid outcome, but if we reanalyze the UKPD scoring system, we can see 1 year after the surgery, there also a reduction about 50% of the cardiovascular instance. So I think the benefit is very similar between the Asian and the Western in this part. In order to answer a solid question in Asian population, we have launched a Taiwan diabetes study. This study already includes 1,000 diabetes patients and intend to follow 10 years. And the inclusion criteria is BMI more than 25 to answer a question about solid outcome of metabolic surgery for type 2 diabetes. We just published our midterm results 2-year study. And in this group of patients, we can see metabolic surgery really reduce the albumin in protein and improve the renal function and improve the peripheral neuropathy. However, we didn't see the improvement of retinopathy to now. So the long-term data need to wait. So the take-home message for my talk is the Western in diabetes and other metabolic disorder. We can summarize there are distinct aspects in Asia type 2 diabetes patient. It's a younger, low BMI, but more abdominal adiposity, higher nephropathy. And the second point is metabolic surgery is safe and effective for Asian and Western patients, but still associated with weight loss. So you need an amount of weight loss. The third is precision metabolic surgery is a solution for diabetes and can reduce the cardiovascular risk, improve neurologic and renal function. Thank you very much for your attention.
Thank you, Professor Lee. And I think we've done with the talks. So I will now like to use the other panelists who've been on this. Dr. Charles Panzheng from China. He's the professor and vice chair of surgery, the director of Center for Medical Research and Innovation, Fudan University, Pudong Medical Center, China, the Center for Medical Research and Innovation of Shanghai, China. Then we have Professor Malfoby, again, one of the most internationally well-known surgeons, an innovator and of the 4B banded ring, which most of us have done. He was also known as one of Hollywood's most famous weight loss surgeons, and now has been in Mumbai, India, and has almost become Indian as we speak. So Professor Phoebe, welcome. He's had multiple presentations and lectures internationally, locally, and wherever else you want. Then we had Chun Hai from Singapore. Chun Hai is a consultant with the Department of General Surgery at Khoo Teck Puat Hospital, and after graduating from the University of Melbourne, he completed his basic and advanced surgical training in Singapore. He's conferred the fellowship by the Royal College of Surgeons, Edinburgh in 2015, and has been practicing bariatric surgery and one of the leaders of bariatric surgery and metabolic surgery in Singapore. Professor Lee, well, again, doesn't need any introduction, is the chair currently of the Ifso Apc Scientific Committee, has been the president of and one of the founding members of Ifso Apc, one of the leading teachers of bariatric surgery in Asia, with one of the largest series of publications. I do remember Professor Lee because I think all of us have learned from him. And he has a name lecture on his name in the same Ifso Apc. So Professor Lee, welcome. Now I'd like to open up this session for various discussions. I'd like to bring on Mal first. Mal, you've seen the East and the West, and you've lived in the East as well as in the West. what do you think differentiates our patients in the East now from those that you previously operated in the West? Mal.
Well, thank you very much, and thank those who've invited us to be part of this session. Very good presentations. I think the three speakers have given us three different perspectives. Dr. Chobby has talked about the genetics, and then Dr. Lee has talked about the metabolic outcomes that are different from what we see in the West. And then we see the incidence of thrombophlebitis and venous thrombosis, again, is less in the Asian population. I think it's a question of lifestyle, and that difference is there. And therefore, the question will really be, should we in the East be treating our patients differently? Should the choice of surgical procedures in the East be governed by these factors that the three presenters have made, the genetics, the less incidence of thrombophlebitis, and the high incidence of metabolic complications? So that is what I would have to say about this. By saying that, I'll go ahead and ask Dr. Chobby, what do you think? With this genetic makeup, do you think the surgical procedures should be different in the Asian area?
Well, Mal, thank you very much. What I suggest is not only the genetic predisposition, but also I would like to bring to notice is our eating habits, which is also very important. And though we know that most of the population is vegetarian population, and we have got all the metabolic problems at a lower BMI, all cardiac problems and atherogenicity and metabolic syndrome and fatty liver. So I think combined it together, I feel that possibly we will have to, I will strongly believe that we have to follow a mid path. So for example, not a very restrictive, only restrictive, but also I think that we have to be very careful about malabsorptive procedures in this subcontinent, because the long-term follow-up is very, very poor. And for any malabsorptive procedure, I think follow-up is very important. So that's what I feel, that we have to keep in mind the genetic predispositions, earlier BMI causing metabolic problems, and of course our habits of eating and doing less physical activity.
Professor Chaube and Professor Lee, there's this question from Dr. Talapur from Iran, where he says, is there any differences between female and male, between Eastern and Western? Are there any differences? What about intra-abdominal and thoracic fatty tissue, especially around the heart, kidney, and liver? So either of y'all could take this question.
Yeah, I think most of the studies which have been done have shown and given importance to liver more than anything else. And I'm not too sure, at least I have not come across any studies which are talking about the chest, fat in the chest. However, there are certain studies which have shown more fat in the pancreatic tissue, which is also responsible along with the liver for producing the atherogenicity and predisposing them to the metabolic syndrome.
Professor Lee, you've done a lot of work on low BMI and metabolic syndrome. Do you think there's any difference between the East and the West as far as this is concerned?
Yes, I think the genetic make the patient different in this region. As I show in the typical case, we are met very young age diabetes, already have a severe diabetes complication like that. So I think surgical may help this group of patients. That is my main interest in research interest now. Yes, but we need data. We really don't have this kind of data yet. I know in Japan they start to run a randomized trial comparing this young onset diabetes. Yes.
Charles, you again are someone who's practiced in China as well as do have a lot of experience from the US. What I would like to ask you is that in terms of the young onset diabetics, yeah, the IODs, which is something that Professor Lee and various other people in Juliana and Chang and everybody has been working in Asia especially. Do you think it really does matter that we should operate earlier, much younger in Asia, and think more in terms of metabolic rather than in terms of bariatric like the West does?
I mean, this is a very good question. You know, it's actually there are more young onset diabetes in China, in East Asia versus Western. I mean, if they are qualified for the surgical criteria, I mean, we don't have any reason not to operate on them. But the thing is that how to choose the surgical procedure, what kind of procedure going to work on them, either gastric bypass or sleeve. I mean, for a younger person, I would prefer to a sleeve. Try to, even we cannot cure the diabetes for young onset diabetes, but we can make that improve the diabetes, which even also benefit to young persons.
Well, let me just, you asked me about my experience having worked in the West and the East. One of the unique things about the East is that we are grouping a big variety of people. The obesity and diabetes in China and probably even Japan and Korea is very different from what I saw in India. India looks more like the West. India and Australia seem more Western. We see a lot of severely overweight people in India who are not diabetics. You know, so there's not a direct correlation between the diabetes and the weight in India. Whereas the 2 or 3 times I've been to China and Taiwan, we're seeing people with BMI between 27 and 35 with severe diabetes. And I think that's what Dr. Lee and CK Wong and Charles are operating on. You guys are not operating. In India, the average BMI is about 42. Am I correct, Dr. Chabi?
Yeah, that's right.
And then if you go to China, the average BMI is somewhere around 34, 35. So this is something we have to look at. I think that area is being grouped erroneously, and to talk about East and West might be misleading because from what I see in India, it looks more like the West than the rest of China.
Yeah, the other point I want to point out that probably in our guideline we use the also use waist circ as the threshold for the diabetes surgery. So if waist circ is over 85 in women and or over 95 in men, probably we can do an even lower BMI patients for the bariatric surgery. The other thing we're going to measure the beta cell function. If the purpose of surgery is for diabetes, we'll make sure we have the beta cell has enough reserve function, like which is not C-peptide. C-peptide, the lower threshold going to be half of the lower border of normal range. So the other criteria for diabetes surgery.
Dr. Lee, do you think probably there is some viral infection that causes this destruction of the beta cells? Because you tend to have patients with lower C-peptide than we have in the East and even in India. Why do you think so?
Virus. I don't think virus infection is key. Yes, because you can see the trend is in this recent 2 decades when economics coming up and the patient getting fatter, and you can see the diabetes incidence coming up. I think definitely due to the genetic factor plus on obesity. We are very sensitive to obesity. Yes, so I think it's that. Yes, but I don't realize India is more like Western. Yeah, I first heard you talk. Yes, that's interesting.
Maybe for I have the postulation that it is probably related to the diet that we take, because since young we take a lot of high carbohydrate diet, a lot of noodles, a lot of rice, a lot of flour-based diet since young. So you have a prolonged exposure of your pancreatic tissue to a high insulin, and you have overworked your insulin for a long period of time, in which they go into burnout phase, in which your C-peptide will come back lower at a same age compared to a Western nation, and then you have your early onset diabetes. That's just one of my postulations. How come the Western and the Eastern diet is very different, and this could be one of the cause.
Definitely.
The other point I always think about that, in between Eastern and Western, we use a different criteria for obesity diagnosis. So we consider use a different criteria for diabetes diagnosis criteria, because the phenotype of diabetes type 2 is quite different in Asia than Western countries.
That's why at some point we should probably just talk about metabolic surgery, because in Asia, particularly in China, there are many patients who qualify for, they really come in and they get operated on because of the metabolic problems, the diabetes. And I think most of you choose the patients because of that. Because with a BMI of 30, many of them, don't quite qualify for being morbidly obese. I know that because I had a surgery for diabetes with a BMI of 31, and my diabetes resolved. Whereas in the rest of the world, if you start doing surgery on people with a BMI of 31, it's going to look like a taboo. And it will be considered cosmetic. But I can tell you, in my own personal experience, I have about 5 classmates who have succumbed because of the diabetes and myocardial problems. And we all had diabetes about the same time, around 2004. And when I had surgery in 2011, my diabetes completely resolved. I don't have any neuropathy and all the consequences. And some of them got blind and they got kidney problems before they passed away. So we have to start differentiating the bariatric aspect from the metabolic abscess.
Jun, there is this question from the audience. So before we continue with our discussion, when do you advise umbrella to prevent DVT? That's one question. And how many days is post-op prophylaxis based on your protocol?
So for using of IVC umbrella, that will be probably the same reasons why you would not give Clexane, which means that you have got bleeding problems, bleeding disorders, or recent upper GI bleed, active ulcer that's bleeding, or recent neurosurgery, which is the reason why you can't give enoxaparin or Clexane. And then you will consider doing umbrella for DVT prophylaxis. But to do that for bariatric surgery, probably we've got to weigh the pros and cons of doing that. So maybe delaying the bariatric surgery to an extent that when it's safe to use Clexane, let's say the patient had got a recent stroke or recent neurological deficit. So maybe delaying a period of time for a few months until the patient is safe. Then that will be probably a good idea compared to putting an umbrella in for DVT prophylaxis. Now, with regards to the second question, post-op prophylaxis, in my hospital, I give a dose during the surgery, and because they have early ambulation, they are up and about on day 1, and on day 2 they ambulate and they go home. So I don't give post-op prophylaxis, but I will consider giving for those at high risk. That means that previous DVT, they have got some blood disorders, or they had got a previous PE before. Yes, then I think I will give for extended maybe 2 weeks or 4 weeks.
What about you, Professor Lee? Do you follow the same protocol? Do you not give post-op prophylaxis except if they've had DVT?
I think we have some painful experience. If we routinely use heparin, we'll have a much increased bleeding. I believe the Asian is a little different with the Western. So my criteria is I only give heparin in high-risk patient, BMI more than 50, past history. For normal bariatric metabolic surgery, especially the patient below 30, we don't use any heparin to avoid the unnecessary bleeding. Yes, that is my principle.
Professor Chaube, do you prefer putting them on oral anticoagulants post-op once they're discharged, or just on Clexane and Whereas
Only on Klaxin, Mufi. Only on Klaxin. And I have a question that when you're putting in a Fortune, when you're putting an umbrella, you're not giving any prophylaxis.
No, I mean I think the umbrella is like a substitute for Klaxane or enoxaparin only in conditions when you are not able to give Klaxane or enoxaparin. Then you consider putting in vena cava umbrella filter.
But it's not the addition to the heparin, isn't it?
Because, no, it's not in addition to the heparin.
Many of the centers, if at all, they are putting in the venicable filters, they have to give heparin during that period. That's an additional sort of thing. That is what was my impression.
I think the ASMBS position statement summarized that IVC filter is not recommended for bariatric per se, but I think if there is a contraindication to give Klaxane or enoxaparin due to some bleeding disorders, then I think we should consider doing that. I think, but my proposal is to that if there is something that's reversible and that's something that you can postpone for a matter of weeks or months, I think the patient will probably wait until then you can get your Klaxane instead of putting an IVC filter in.
The thing is, what I think we are treating patients with antithrombotic agents based on the experience we had from open surgery. During the day of open surgery, we kept the patients on the table for long times, 2, 3, 4 hours. We kept the patients in bed with nasogastric tubes. We didn't ambulate them, and so we had all this pulmonary embolism. With laparoscopic surgery, I'll tell you, in the last 4 years I've been in India, working in a high volume center, I have not seen one case of pulmonary embolism. And when I was in California, it was like I averaged, when I was doing open surgery, at least one a month. And that was my most common cause of mortality. So I think the prophylaxis, chemical prophylaxis, is as important as physical prophylaxis. Getting the patient up after surgery, ambulating the patient, and using a vena cava filter is too aggressive. If you do it, you're going to have more complications than not doing it. But that would just be my own caution.
But Mal, I think I will agree with you also, and I think Mufi is aware of this fact that I think that is the reason why I am not in favor of doing any IPOM or any hernia repair surgery with bariatric surgery, because that reduces their mobility. You know, so I mean, this is one of the reasons, very important reason, and I agree with you.
No, there was there was a question.
Use
Yes,
umbrella. That's the case. We do the inguinal hernia repair at the same time. The patient developed the leg thrombosis 2 weeks later. So we need to put an umbrella for that case. So I think the suggestion from Chobi is very right. Yes.
Good. Go ahead, Murphy.
There is a question from the audience. In case of post-op hemorrhage, do you discontinue anti-thrombotic drugs? I think I'll just give the answer, and if all of you all agree that yes, of course, you stop in case there is bleeding, right? So all of you all agree on that. Just one last question before we do the polls was, what in case of COVID? We do know that it's a thrombogenic disease. Have you all increased your prophylaxis for your cases? Have you changed anything as far as the DVD prophylaxis goes for any one of you all?
We have not changed anything.
Same protocol. No change.
You just mainly make sure the patient doesn't have COVID before you do the surgery.
Yeah.
You do RCT, PCR testing, and antibody testing before you do elective surgery. Yeah.
Okay.
Thank you.
And now we go for the polls. Okay, so there are 2 questions. Anala, do you routinely evaluate the VTE risk after every bariatric procedure? Do you routinely evaluate the VTE risk on every bariatric procedure, a patient before surgery? I think whilst the poll is amongst the audience, out of the 6 of us who are on the screen, would you all routinely evaluate according to Caprini score or any other score that you'll use?
We don't.
Whilst we are waiting for the results?
We don't.
I don't. I do not.
June, do you do the Caprini score?
I don't have a routine evaluation for VT risk for every patient, but we do the same protocol for all of them.
Charles?
Yeah, I do routinely do every patient on the VT risk, but I don't use Caprini score because the patient over 24 BMI and over 60 BMI is all in 1 point, which is not suitable for obese patient. I use the Michigan Bariatric Surgical Collaborative protocols for the VT screening and treatment.
Our results suggest that 50% at least routinely evaluate the VTE risk. 29%, like Prof. Mal, do not do that, and 20% said it depends on the case. So I think it's there. I think medical legally, it might be better at least to evaluate the VTE risk. God forbid if you land up with a problem. Well, the next one is, what kind of VTE events have ever occurred to your patient group? We do know Malice said that they did occur while he was in California, nothing in India yet. For the rest of the group, have you had pulmonary embolisms, DVTs, portal vein thrombosis, mesenteric vein thrombosis? None of the above. I'll start with you, Prof. Lee.
I made more different thrombosis than others part, but I do make portal vein thrombosis for sleeve in 2 cases. Mesentery, maybe 1 case. Pulmonary embolizer, never. Yes.
Mal, any portal vein and mesenteric vein thrombosis in your group in India that you've seen?
Yeah, we had one portal vein thrombosis that ended up as a fatality. It occurred about 2.5 weeks after discharge from the hospital. And that is the only case we had. I think there might have been another one before that. That's the only time when we do consider choice of procedure. Any patient with history of DVT, we try to triage them away from doing a sleeve, because the 2 cases where one which I definitely saw during the last 4 years and possibly one that was before I got there were patients who had sleeves, and both of them did not end up very well.
Okay, we've got the result here. So the thing is that with conventional prophylaxis that we use, and this question is for both Charles as well as Prof. Lee, Prof. Chaube, do you think you can prevent portal vein and mesenteric vein thrombosis?
No, I don't think so. I don't think it is going to prevent that.
Yes, I think dehydration is probably the most important. Yes.
Probably, so yeah, dehydration. I think so. I agree with you.
Because the reason I asked this question is that a lot of youngsters believe that by giving routine DVT prophylaxis, they feel that they can prevent mesenteric vein and portal vein thrombosis, and that's a more dreaded complication, of coursingly. So I think dehydration, like all the experts on this group have said, is very, very vital. I think that's the most important thing to do and see. And if you were to land up with one of these, the problems are far, far obvious. And I think we're probably done with our session out over here. So thank you so much, Professor Malfopi, Charles, Chunhun, Professor Chaube, Prof. Lee. As always, it's such a pleasure, and hope to meet you all in person soon, and so that I can probably hug you guys rather than do a namaste. Thank you so much. Bye-bye.
Namaste. Thank you very much.
Bye.
Well, I think that's a very exciting session. We kind of overrun a little bit. So I'm going to try to finish off, draw the short straw. So the next session is me. So I started the meeting last days, and so I will finish that off. My name is Ken Loy. I'm the Ifso Executive Treasurer. And this session appears to be quite short, but I have to apologize for our allied health and our physician, because to me, bariatric surgery is not just a surgery. It's like fighting a war, and we have 3 layers of armors. And the most important armors is dietitians, physicians, and also probably endocrinologists as well. So I think I'll introduce everyone. We have great 2 panelists. John Dixon doesn't need to be introduced anymore. I think he's been introduced a lot of time, and he's our trusty physicians that keeping us safe and making sure that we're doing the right thing. And Professor Suming An, I think from Korea, and a very extensive experience. And I understand with Korea that bariatric surgery is now really taking off because of the approval from sleeve gastrectomy. So you have a lot of input on nutritional side, etc. And our 3 speakers today, I think it's we make them work because both Caroline worked with Mufi, Stephanie worked with me. They both get award last year in Ifso in Spain. So we decided to put them to work, and give us some of the insight on how they look after bariatric patients. And Tam, I don't need to introduce as well. She's our trusty endocrinologist in Singapore, and is going to debate with us about diabetes resolution. Picking back on last talk as well, you understand about the Asians is different than Caucasian. So we'll kick off with the talk first, and then we'll have a good discussion afterwards. I'll see you guys back in about 15 minutes.
Thanks, Ken. Hello, everybody. My name is Stephanie Gilroy, and I'm here to talk to you today about the nutritional complications after bariatric metabolic surgery. I work with Dr. Ken Loy in Sydney in Australia. So this is our caseload mix. And as you can see, we have around 75% of our patients who go through with the sleeve gastrectomy. Today I'm talking to you about some nutritional complications after bariatric surgery, and myself and Caroline got together to discuss who would cover which topics. So I'll be talking to you today about food intolerances, food grief, and some nutritional complications. So lactose intolerance is a common food intolerance after bariatric surgery. Lactose is a disaccharide that's found in milk and milk products, and is usually broken down by the enzyme lactase in the gut. So following metabolic surgery, there can be changes in the levels of enzyme, and also in terms of stomach acids, and also the speed of transit time through the gut can increase. So we find that common symptoms include abdominal cramping, bloating, nausea, or gas, and also some diarrhea. And symptoms can usually appear about 30 minutes to 2 hours after a meal. So generally, we advise people to swap to lactose-free options or to use fortified plant-based options to ensure that they're getting adequate calcium, or even to use Lactase, a lactase-based enzyme supplement. Other food intolerances are quite common, and we find that a number of these include caffeine, oily foods, spicy foods, and sugary foods, which can result in dumping, which Caroline will talk to you about. So a study back in 2017 from a British group found that food intolerance was reported in 176 of the 249 post-op patients. And this was a cross-sectional study looking at the GI rating scale and also food intolerance questionnaires. With regards to food grief, I think food means different things to different people, and people value food in different ways according to their social identity, according to their religion background, and also their cultural beliefs. And when people have bariatric surgery, they do need to adapt to the way that they eat, and this is important that we give people advice on this. So we talk to them about eating and drinking separately, perhaps considering potential food intolerances, They will obviously need to adjust their portion sizes and also the speed of which they eat. Because all of these can result in gastrointestinal symptoms if it's not managed properly. So there's a steep learning curve that people go through when they have bariatric surgery, and a lot that we need to cover in our dietetic consultations. Nutritional deficiencies is well documented, and this is a recent study from our group from this just been published, and we looked at sort of our group of sleeve gastrectomy patients, so 565 patients with a mean BMI of 42. And interestingly, we found that vitamin D deficiency was noted in 45% of the pre-op cohort, and this significantly decreased to 15% at 12 months follow-up. So the prevalence of hyperparathyroidism preoperatively was 32%, and this also decreased at 12 months post-op. And we have as sort of quite a straightforward protocol that we follow with regards to vitamin D supplementation. Interestingly, we did find that the prevalence of folate deficiencies significantly increased at 12 months from 7.7 to 19.2% of our patients. And this is particularly key for women of childbearing age, which the majority of our patients would be. So lifelong monitoring and tailoring of regimes is really important in terms of the management of these patients. So just to sum up, preoperative assessment, health and performatory, lifestyle, cooking skills, nutritional status is really important, regular follow-up and monitoring. The psychosocial support is important from the point of view of food grief and ongoing support after bariatric surgery, and tailored advice to encourage self-management. Thank you.
So I'll be talking primarily about the long-term complications today. First up and most important is dumping and hypoglycemia, which I think is probably the most damaging and which affects the patient's quality of life. Late dumping syndrome is most common among our patients because it causes your hypoglycemic type symptoms. It is also important to be able to recognize these signs and symptoms. But in order to confirm your diagnosis, a 3 to 5 hour OGTT with corresponding insulin levels or even a continuous glucose monitor works great to be able to confirm that. Once you've got your diagnosis, it's important to remember that your goals of management should be to treat low blood sugar levels promptly, avoid over-treatment, which could lead to rebound hypoglycemia and could possibly lead to weight regain as well, and also to prevent future hypoglycemic episodes. However, if you find that your dietary intervention is not giving relief to your patient, it is probably a good idea to get in your endocrinologist, who will be able to add on some pharmacological therapy, mostly in the form of acarbose, which is an alpha glucosidase inhibitor, which will help stabilize blood sugar levels. But it is a long process and it will require close monitoring, so you will have to be patient with your patients. Next up is nutritional deficiencies, which happens before bariatric surgery as well, given poor food choices of our patients, side effects of medications, sedentary lifestyles, and chronic dieting. Hence, baseline levels are very important. When we talk about surgery, given reduced intake of food, food aversions, and intolerances, your food deficiencies, your nutritional deficiencies tend to exaggerate. Reduced gastric acid, reducing intrinsic factor, which happens in your sleeves and your bypasses, bypassing parts of intestine, delaying mixing of pancreatic and gastric juices will all sort of lead to nutritional deficiencies. Hence, it is important to understand the type of surgery and supplement your patient accordingly. These are the most common deficiencies, but of most critical to state is thiamine, which can cause irreversible damages to your patient. So pick it out early and supplement even if you suspect it without a confirmed report. Current worldwide guidelines will help you supplement your patients accordingly, but important to pick a guideline that is most closest to your patient's population, given various cultural differences, dietary differences, patient lifestyles, difference in eating patterns. So pick up a guideline which is most suited to your patient population. We published the guidelines for the Indian population in 2016, keeping in mind the majority of our patients are vegetarian, keeping in mind vitamin D3 deficiencies, which are very high given religious practices and clothing practices. And given all of that, we found that when we supplemented our patients accordingly, that 1 year post-bariatric surgery, the nutrient deficiency levels actually came down. Weight regain is another effect in the long term after bariatric surgery, which happens fairly around 2 to 5 years post-op. It is very multifactorial, it is very patient-specific, and will need a multidisciplinary approach. Multiple causes of weight regain are primarily dietary. So if you look at dietary intervention, you're looking at increasing your protein intake, improving and increasing low glycemic load foods, using fiber supplements, using calcium-rich foods, and also essential fatty acid supplements, which will help reduce fat absorption and help you get control of the weight gain. If all of that fails, it's important to also look at pharmacological intervention, which you will need a bariatric physician or an endocrinologist again. Multiple drugs are used for weight regain. However, some may not be available in the country that you live in. For example, we only have liraglutide available in our country, even though we know that topiramate and phentermine are most effective. So we are hoping for more sort of research to come through. In conclusion, a multidisciplinary team is very, very important for a successful bariatric practice. Nutritionists are important to be able to prevent and manage nutritional complications and also bridge the gap. And nutritionists need to have a thorough knowledge of surgical procedures, potential deficiencies, to be able to manage bariatric patients effectively. That's all for me. Thank you very much.
I'd like to thank the Ifso Apc committee for inviting me to present on the topic of diabetes mellitus post-bariatric and metabolic surgery. These are my disclosures. And I would like to cover in the short 10 minutes and give it justice, hopefully, the cause of diabetes after metabolic surgery, the impact of glycemic control, including remission, and the difference in types of surgery on impact of diabetes, if there's any, and the management of diabetes after metabolic surgery. This is on the background for us, and I must stress that we are treating diabetes and must remember it's a chronic and progressive disease, and that it results from multiple mechanisms of pathophysiology. Therefore, our treatments must be targeted to that, and it actually is associated with complications and increased mortality, and that's what we're trying to prevent. Obesity, it's in a lot of type 2 diabetes, and also the reason of our treatments here. It's also a progressive and complex disease. With the advent of a bariatric surgery, I think the observations have been made such that now diabetes resolution or remission is now possible. As you can see, the meta-analysis here, that up to 78.1% of patients after bariatric surgery can see their diabetes get resolved, and in as high as 95.1%. As well, in the 21st century, we no longer just have like metformin and sulfonylurea like we did in the 90s, but really a whole armamentarium of medications to deal with this very complex disease. And some of these medications, when combined, can even cause HbA1c drops of 1.5 to 1.9%, cause weight loss, and even cause benefits to the nephropathy to the kidney and cardiovascular benefits. So diabetes medications have upped their game, and even just weight management by a primary care physician. There was a study conducted using VLCD, and we can see in 46% of these patients, they can achieve diabetes remission with just medical weight management, and this can be sustained up to 2 years. Therefore, it seems like for metabolic bariatric surgery to prove itself to be more effective than medical therapy in the control of type 2 diabetes, there needs to be head-to-head treatment with RCTs. And here you can see 11 RCTs that have been done at the time of this review in 2016. And It varies from types of procedures, but it's always a control arm or best medical therapy for diabetes, and randomizing different types of patients with 12 to up to 60 months of follow-up here. And definitely, clearly, what we can see, despite the different remission criteria, is that diabetes surgery or metabolic surgery is definitely more effective in controlling HbA1c or glycemic control compared to medical therapy. Of course, the diabetes remission rates vary depending on the targets that have been used, as you see, the duration post-op that we assess it, and even the types of procedure. At 1 to 2 years, you can see anywhere from 52 to 73%, to 44 to 90% with Roux-en-Y gastric bypass, 95% with BBD, and you can see this effect wanes off with time. But nonetheless, metabolic surgery can result in at least 2.5 to 3% drop in HbA1c over time, at least 12 to 24 months, and this usually can be sustained, and this is 1.5% above best medical therapy. Now, in terms of new therapies like the ESG, all I can say is there's very limited data. Maybe the results look promising, but we need more data there. So are all these very promising data in terms of diabetes remission, are these glycemic improvements durable with metabolic and bariatric surgery? I take a lesson from the Stampede trial at 5-year outcomes. As you know, this is a randomized controlled trial, 50-50 in each arm of intensive medical therapy, gastric bypass, and sleeve gastrectomy. And you can see that at 5 years, diabetes remission defined here was found in 22% in gastric bypass and 15% in sleeve gastrectomy, compared to 42% and 27% at 1 year. So you can see diabetes remission has reduced, or diabetes has relapsed in about 50% of patients. Yet you can see that about half of the patients still managed to get good glycemic control of less than HbA1c. Now you can see that these are the number of percentage of patients who are on medications. That in the Roux-en-Y gastric bypass, there's a greater number of patients without medications and still do have good control. Now, some of the factors that have been found to be associated with better diabetes remission are reduction in truncal fat and better beta cell function. When we looked at our own cohort in Singapore in a multi-ethnic study, we found that there were about 80% of patients in remission at 1 year, but at 5 years, this is down to about 43%. Therefore, about 50% of people in remission initially had so-called relapse. But this is not all lost, because you can see that overall HbA1c is still very much controlled, and even at 5 years, not bad. I mean, compared to when they started out, a 2% drop there, even in patients who've never remitted. But factors that are associated with a rate relapse are people who didn't lose as much weight or lost in the regain, people with longer duration of diabetes, greater HbA1c, and there were more people using insulin, reflecting a lower beta cell reserve to start off with. But we did not find any differences in ethnicity in the studies. So in terms of procedures resulting in better metabolic outcomes, I think this is always an ongoing debate, which is better than others. I know that many people believe the bypass is better, but in fact, it is true that surgeries that produce more weight loss and perhaps more gut physiology changes that may then result in better insulin secretion do better. But the head-to-head trials are really far and few in between, especially in terms of RCTs. So let's take a focus into Roux-en-Y gastric bypass and sleeve gastrectomy, the two most commonly done procedures right now in head-to-head trials or RCTs. And looking at these 4 trials here, you can see that there is really no significant difference between the Roux-en-Y gastric bypass and sleeve gastrectomy amongst these groups of patients, about 50%. Now, even if there was a difference, at most, there'll be a 2% favoring sleeve gastrectomy or 15% favoring Roux-en-Y gastric bypass. At the end of the day, I think we need to then individualize each patient and decide with the patient actually which surgery is better for them. And this is taken from the Cleveland Clinic group of 900 patients, and they did they used 4 pre-op clinical parameters, basically to reflect a patient's basal beta cell function and how severe that, and then calculate the score to see how severe their diabetes is, and then decided will recommend the types of surgery based on the known remission rates at 1 year that you can see here. At the end of the day, don't forget the patient. We need to also consider other factors, what medications they're on, other medical conditions they are, what kind of risk group they are, before we decide. And it's just not all about sugars. And at the end of the day, we also want to reduce the cardiovascular and microvascular risk without causing more complications for these patients. What about managing diabetes after surgery? Just remember, it's just beyond glucose. Please remember your ABCs, HbA1c less than 7% at least, and this is to be tailored. Blood pressure parameters for patients who have nephropathy or higher cardiovascular risk, this has to be lower, and cholesterol, LDL cholesterol targets here. Now, annual screening for microvascular disease still needs to go on, even if the patient is in remission, and needs to be done for at least 5 years post-op, even if they're in remission. And remember, the aim is not to take the patients off medications or how many medications we can take them off and how fast, but really is to control the diabetes and their risk factors at the end of the day. So for the immediate post-op period, we tend to take our patients off all therapies and then observe them on a sliding scale rapid insulin. There's usually a very, very rapid improvement in glucose levels even in the first few days while they're in hospital. We generally avoid sulfonylureas or rapid and premixed insulins and SGLT2 inhibitors, which can be associated with euglycemic DKAs and even dehydration, especially around the peri-op period. Now, metformin followed by DPP-4 inhibitors can be used if the sugars are still high. These tend not to cause hypoglycemia. And if needs be, for insulin, we tend to use basal insulin. Now, don't forget the hypertensive medications and the lipid-lowering medications. If the patient's a beta blocker, please keep them on the low dose. ACE inhibitors, please keep it if they still have albuminuria. And beware of diuretics, because this can cause a lot of hypovolemia and hypotension. Lipid-lowering medications should be continued, especially in those with established CVD. Now, then, if the patient continues to still have diabetes, there's a whole armamentarium of medications that we can choose from. Now, again, patient factors are very, very important. We tend to choose medications that do not cause hypoglycemia. And definitely, even after patients have lost a lot of weight, many patients are still overweight and obese after surgery. We tend to choose drugs that are weight neutral or even can cause weight loss, like the SGLT2 inhibitors and GLP-1 RAs. In fact, these medications have shown in large trials to have renal protective effects or even cardioprotective effects. So at the end of the day, when we try to treat the patients, we must remember their baseline medical conditions. And in terms of even just weight loss, you can see there are all different types of medications that can still be used after surgery, though not many drugs have been tested. And even in once a week semaglutide, it can even in the step 1, 3, 4 results, it can cause even up to 18% weight loss in patients. And at the end of the day, again, the hard endpoints of cardiovascular risk reduction is very important here. So in SGLT2s and GLP-1s have really shown very positive results in terms of reducing cardiovascular risk factors and even heart failure, mortality, and in some cases, renal protection here. And in terms of for the post-metabolic bariatric surgery, the Cleveland Clinic cohort group showed that in the 6-point maze here, in the 6-point maze here, you can see the relative risk reduction of 40%, and in the 3-point maze of stroke, MI, and all-cause mortality, there's a relative risk reduction of 38%. At the end of the day, I think metabolic bariatric surgery has really raised the bar for diabetes therapeutics, and we're really thankful for that. And it is more effective than best medical therapy. So I do see that the gap is really closing with improved medical therapeutics and even medical weight management for type 2 diabetes. Now, the impact on glycemic control is still largely durable, though we do see a large proportion of patients relapsing, but still about 50% tend to be still in remission with less need for medications. But remember, they still need to be followed up for a long period of time. Now, we do not have a lot of long-term RCTs for head-to-head trials, but in Roux-en-Y, gastric bypass, and sleeve, at the moment for 5-year studies, there's really no difference. I think more data is needed, especially in Asia. And we do need probably localized calculators to risk stratify and maybe help the patient decide which surgery may be better in terms of metabolic outcomes. And remember, at the end of the day, we are managing diabetes, so do not forget the ABCs. Just get the patients to target and reduce their risk for diabetes complication and improve their quality of life without causing more complications. With that, and I thank you, and I'll be happy to take questions.
Great. Thank you for the speakers. And I mean, I promise next time that when we meet physically, there will be a very solid session of allied health. It's just unfair for my physician and dietitians. And I mean, both Tam and John Dixon, I wish sometimes I say, just give them 2 hours, and there's so much to learn from them. But then again, this probably not the right way, and our dietitian as well. So you can see that I think there's a lot of talent here. So I'll kick off we got 10 minutes for session planning. And Stephanie, you might want to mute if you, because we're hearing echo. So I think I'll ask my panelists to comment. I guess, you know, maybe John, you want to comment about the physician side of things? I think the diabetes things we all surgeons aim to cure, but looks like we just managed to sort of maybe remissions and reductions, and that's what we're doing, isn't it?
Well, I have to say, I want to congratulate all the speakers for getting so many important facts through in such a short time. There were gems everywhere there, so I really didn't know where to head. They were terrific, and they were really focusing on the key points. Stephanie, I had a little query about the question just at the start when you were talking about food intolerances and so forth. I just wondered about food intolerances and the specific procedures that were done, because I find that the procedures are often quite, the food intolerances that we experience are quite, or the difficulties with digestion are quite very much related to the type of procedure. Do you find that that's?
Yes, definitely. So, for example, with the gastric sleeve, we're often finding reflux is a really common issue, whereas perhaps with the gastric bypass, dumping syndrome's more of a concern. But it's really important to also establish pre-existing issues with food as well. So, you know, what reflux is like prior to surgery, so we can have a sort of point of comparison. Obviously, this is a discussion with the surgeon as to which way they'll decide to go, which procedure will be chosen. But yeah, it's sort of one of those things that's important to spend time with people discussing, because often, you know, if you can correct some sort of, you know, food intolerance or help them out with some food intolerances, it really helps to manage those gastrointestinal symptoms. Particularly, for example, we're starting to find issues, say, with FODMAP intolerances after surgery as well. So yeah, it's something to make sure that we're spending time with people discussing.
I think, Conway, you also very much focused on the fact that really we're not seeing a big difference in diabetes outcomes with the procedures, and therefore we can really look at other things that might be relevant to the patient to select the procedures, rather than simply what appears to be gastric bypass is better. You know, and I think you emphasized some aspects of that. Did you want to comment on the things that you think about between the gastric bypass and
Sure. And thanks for the empathy. That 10 minutes was really a crash to really squeeze everything. I'm sorry if I couldn't bring some points across. And one of the points I was trying to bring across was that when, of course, remission as a diabetologist is a bonus. I think it's just how the way surgical results have been reported. I respect that, and I think it's needed. So I think with remission, that's how it's looked at. And even when you look at the percentages, if people can get down there with fewer medication, not just remission, but on the whole cohort, and fewer medications, and that's what we see with a lot of the surgeries. I think that's not often talked about. It's always the side point, you know, but people just focus on the remission rates and the HbA1c. But if you can get to that level with just 0.6 average medicines as opposed to 4 or injectables, that's a bonus for a patient. It's a bonus for diabetes. And with that drop in HbA1c, and if you can just sustain it for just a few years, there's also that legacy effect, you know, of potential benefits that we've seen in some of the studies, like our perhaps the UK PDS and our our early insulin studies as well. So I think in terms of that, I also interpret when I look at the results in terms of how many medications they're on, and even insulin. You know, for example, the Stampede, they started at 44% insulin use, and at the end of the day, it dropped down to 4%. You know, that's like a huge improvement as well. So in terms of our own data in Singapore, being a multi-ethnic population, Asian population, we actually found that initially bypass seemed to have done better for the diabetes, but when we corrected it for post-op weight loss, we found that that kind of negated the effect of the types of bypass. So the mechanisms of diabetes are multiple. So I think each person will also have different interplays of the pathophysiology. Some maybe be more insulin resistant, some more GLP-1 lacking, some more insulin lacking. So I think if that surgery does more for this person, brings the weight down, is very insulin resistant, they do better. You know, so I think that's how we see that post-op weight loss acting on in addition to that. So I think that a lot of studies show that bypass may be a little bit more beneficial, and I think clinically we do see that. But again, before we go out and make recommendations, we really need data, including in our own patient cohorts, because they're different surgeons as well, right? Yeah.
I might ask Professor to comment. See, I think he was before that he was quite interested about the diabetic resolution thing, because I guess in Korea they're starting to uptake a lot of sleeve and etc. aim at treating bariatric surgery. But as you've seen from now, the cohort patients are all different in Singapore, India, Australia, and so in Korea, I guess you might have your own idea. Do you want to pick their brain, or if you want to see what you think about it, Professor So?
May I ask a quick question about dumping syndrome? Going back to the Stephanie and Caroline lecture, I saw you saying the frequency or instance of dumping is a little higher in the late dumping cases. And my feeling is, in my practice, I more frequently meet the early dumping patient. Do you think there is some reason why in Korea or in your country there's some differences of instance of early or the late dumping? It depends on it maybe depends on the food per se or the eating behavior as well. Let me have your experience about that.
Maybe Caroline can comment that, hey? Yeah.
Yeah. I think with the late dumping, the reason we see it in our patients also is because it affects them more than the early dumping. So they sort of have your dizziness and the very severe symptoms. I think what I feel is that the early dumping tends to get ignored because it's for a shorter period of time. It often gets confused with a lot of other things that are going on immediately after surgery. So that's my take on it, that patients might be experiencing more often but not recognizing it because your things like your nausea and vomiting and a stomach ache, those are things that sort of get confused with a lot of other symptoms. The late dumping affects their quality of life because when they're at work or they're out and they get that dizziness and they feel those blackouts, that's when they really come rushing to us to say that something sort of gone wrong, is my interpretation of probably what it is. But also the food choices in our country. So we do have a lot of a sweet intake in terms of sugary kind of foods which are included in day-to-day cooking, which sometimes gets ignored. If you don't probe patients enough, you don't know what's causing the dumping. So it also could be our cooking practices and the cultural differences in the way our food is actually cooked primarily. Stephanie, if you have anything to add on that.
I think, yeah, absolutely, exactly as you've said, Caroline. And I think in Sydney, we're seeing a real diversity in patients who come through the door because we're such a multicultural society. So again, establishing, I guess, eating practices and And also just checking through with patients that they understand around the sort of the recommendations for eating and drinking separately, and avoiding high GI foods, and watching things like their fat intake as well as their sugar intake as well. So yeah, that thorough sort of dietary assessment is important at every stage to see, you know, if there's anything that can be changed, because often it's quite a simple solution.
You know, in the 5 countries. Okay, go ahead, please.
Okay, go ahead.
Don't go ahead.
There's a question from the panel. There's a question.
Yes,
from
I was going to flag that, but yeah, and I mean, this is actually an interesting question. I guess
it's a very important one.
It is. It's interesting. I know what John talking about food intolerance, because I think food intolerance living through the time of the lap band surgery, a lot of the symptoms are actually sometimes surgically related, and some of them are food related, and different culture eat different type of food, different density, and trigger off different symptoms as well. I mean, that's my surgical interpretation, which probably wrong, but I'll be guided by you guys. Now, that question in the floor is quite important. It's asked by Mohammed. So he had a patient with Guillain-Barré-like symptoms and signs secondary to LGBP, laparoscopic gastric bypass, okay? LGBP, and performed 6 months before. So all the medication are on time. Is it related to the GPT, or is it some other etiology? Because that's kind of an irreversible thing, and that's important for a dietitian to work out. Or endocrinologist, I guess.
I'd like to.
Guillain-Barré, like, I guess, is then a ascending weakness type thing, and I mean, right on top of my mind is thiamine deficiency, because it also can present with walking issues like ataxia and weakness, and even copper deficiency, which is often not detected. Yeah, guys chip in there. But so, I mean, I'm not sure whether this Guillain-Barré is related to this, but if we talk about something quite similar, thiamine can happen very quickly because it's water soluble, especially patients not eating well and vomiting, and they take a lot of carbs, then they rapidly get very weak. And copper usually a bit longer. Yeah, sorry guys.
It's very late.
Yeah, no, I was going to say to rule out the B1 deficiency, if at all that was the case, and copper obviously. But yeah, that's a tough one, I guess.
So
it's hard to measure thiamine, so sometimes we just do basic labs and just give an IV thiamine and think about the rest later. Yeah. It's so hard to test even in Singapore.
P12. There's data on this. The risk of having Guillain-Barré syndrome in the months after bariatric surgery is very, very low. It's a rare disease. The risk of having thiamine deficiency causing exactly the same symptoms is extraordinarily high compared to the other. It is going to be thiamine deficient because it's only 6 months. It's not copper. And the other aspect of this is that this patient will have lost weight quickly, and they may well have had up GI symptoms. We've had patients like this. This patient with neurological damage will have a positive CT. There will be deaths of cells within the brain, and there'll be and so thiamine deficiency, and then you can look at the other things. But we've had a case of quadriplegia, extending to quadriplegia, exactly this, and it was diagnosed and treated as Guillain-Barré syndrome by a neurologist, and we didn't know anything about it until it was one of our patients, until we were asked to come and see the patient in hospital because they were deteriorating.
Here we go. It's not that straightforward.
It is. It is immunological condition.
B12 can also do that in 6 months, but yeah, I mean just cover
B12. But what we're not. What we've not seen. 6 months. 6 months.
Yeah, it's a bit longer. Yeah. More stores, but.
B12. Yeah, we got it.
It's that, yeah. Actually, I have a question for Caroline in a way, because I presume you see quite a substantial number of vegetarian patients in India. So I think if already pre-op, they are kind of deficient, especially in iron. So how does that actually determine what type of surgeries you do, like the bypasses type surgery? Because it's quite hard. Yeah. keep up.
Yeah,
Sometimes.
so I think what's critical is their baseline reports. So we do get their reports, try and get all their reports before the surgery. We've had cases where we've had HbA, we've had hemoglobins as low as 6 and 7 even before surgery. So we've deferred surgery until we've managed to up their hemoglobin levels and then gone on with, with procedures. And what we've also found out is that post-surgery patients are a little bit more aware. They're more better off with getting tests done regularly. A lot of them are living with deficiencies that they didn't know about. And we find that post-surgery, because of follow-up, because they've got to get reports done, the levels actually improve because there's constant reinforcement of supplementation. But yes, B12, D3, and iron is something that we find, pretty common. B12, because again, from a diet point of view, I think I see it in almost every second patient that walks into the clinic. So we do use intramuscular injections more than just the sublinguals because it helps us get their levels up higher. But yeah, and then post-surgery, we do have them coming in to get regular sort of shots, so that their levels are maintained.
Now, I think we probably should poll. And for closing, I want to thank the panel. I mean, clearly, as bariatric surgeon, you can see that if you encounter anything after surgery that is not related to surgery, but the patient had a problem, you need to ask for help. And the help is these people that you've just been speaking to. I think they got a wealth of other medical knowledge that we don't presume we have. And to look after our patient properly, you need a team, and this is the team. And for Asian Pacific especially, we're about to rewrite the guideline for 30 years of bariatric, and we'll be drawing on you guys, and I've been pushing to have a set of guidelines that is suitable for our Asian Pacific patient, because the last 30 years it's been North American, Anglo-Saxons, European. I think the next 20, 30 years is going to be Asian Pacific, Middle East, and we would need our own set of nutritional dietetic guideline. And I wish you all good luck. And I think next year we have a full day ongoing session with all of you guys, which I think I'll come to you guys more than anything. There's nothing much to learn more about surgery. So thank you very much.
Hold you to that, Ken.
Poll time now. Let's poll time. Now let's see if that works. They try to set up the poll.
Sorry, there's no poll apparently.
No poll.
No poll. So we're actually about to ask. In fact, it's actually not a poll. We're just asking people what their practice of surveying. Oh, here we go. There is a time no assessment of deficiency best assessed at what time. So I guess you hear a lot of conflicting informations about. I mean, I think nutritional assessment and blood tests are guideline, but seeing the patient and listening to their symptoms is probably important. But we routinely, for the first 1 year, keep them on short leash, and then, but the follow-up need to be consistent. So let's see what we have at the moment before we close off the session. Everyone press, close off the results. Here we go. All of the above. That is what we actually wanted, because I think most of the time you need to assess patient at different levels. As you're aware that the complications and problems can arise early, late, somewhere out of the blue in few years even. So I think we need ongoing assessment, which means that you need a team. So thank you very much on that note, and we move on to the next session now.
Thank you. Thank you. Thank you.
Well done. Now the next sessions will bring on different panel. While they're jumping on, I'll introduce it, because I strongly advise a lot of surgeons, especially young or experienced, to record their own surgery, because that's kind of a way to self-learning, self-taught, retrospectively review what you do. And I want to thank everyone that who sent in their video because they are all very high quality, and it's with the pain that we can only select it for. Doesn't mean that they are the best, but the others are also good, and we encourage people to continue to do that because that is the way we can share knowledge. And once someone had a complications or some difficult cases, it will be a good thing to know. So we had 4 video, and my 2 expert panel that we had is Mohammed Talpo, who's an Iranian surgeon that we know for a long time. You're a little bit dark with the background, but probably a morning time for you and evening time for us. And welcome. And also Dr. Nick Kozai, who is Malaysian surgeon that we know very well as well. And now we have 4 video that we selected. We're going to go in a row, and then I'll ask my panel to comment on what they think about the video, and then maybe have a poll afterwards. So we can roll the video now one by one.
This is a case of a laparoscopic conversion of a banded Roux-en-Y gastric bypass with elementary limb gangrene, secondary to an internal herniation between the gastric ring and the gastric pouch. We've done 4 such cases already. This was a 43-year-old female who was operated for a Roux-en-Y gastric bypass 3 years back, lost 42 kilos, was asymptomatic until she developed this sudden acute abdominal pain. That shows the ring along with the remnant stomach. The CT scan showed the ring along with dilated jejunal loops just above it. On an Excel trocar entry inside the abdomen, you saw elementary limb gangrene with herniation through the ring. Now, when we divided the ring, in this case, you will see the remnant bowel suddenly getting distended. Now, this usually happens with a small nidus of bowel that herniates between the ring and the pouch, and then that kind of mitigates the rest of the elementary limb to follow suit, and because of the vomiting and retching. On removing the ring, we decided to convert this to normal anatomy. So we divided the gastric pouch. Now, there are various options that you can choose in this case. This is the remnant gastric stomach on making a gastrotomy. You can see it is distended. That's the bougie. You make a posterior gastrotomy and then fashion a gastrogastrostomy with a 45 stapler. I prefer closing this gastrogastrotomy in 2 layers. Now, what we do notice is that the options that you're left with, depending on how serious the patient is, either to convert to normal anatomy or to refashion it by taking a new elementary limb, refashioning a gastrojejunostomy, and redoing the entire gastric bypass. The chances are that when the patient is septic, like in this case, and additionally this patient also had COVID, so we did not want to take any chances and thought that the best thing would be to convert this patient to normal anatomy. If you were to convert it to a refashion Roux-en-Y gastric bypass, the options you're dealt with are to measure the elementary limb, then to measure the entire small bowel limb length, and decide the amount of biliopancreatic limb you would like to leave, along with a new elementary limb of maybe around 75 centimeters to prevent reflux. The chances of a gastrogastrostomy leaking vis-a-vis a gastrojejunostomy are much lower, and therefore the preferred route in a septic patient would be to convert to a normal anatomy and let the patient live another day. Then we proceed to divide the elementary limb just where it forms the jejunojejunostomy, so that The biliopancreatic lymph then continues to go on to form the common channel. We divide the mesentery in such a way to complete the remaining part of removing the gangrenous bowel. Then we bag the gangrenous bowel and remove it through one of the side ports. This dilated port is then closed. This patient did very well and was discharged on the 4th post-op day.
Hi everyone, this is a video on the laparoscopic excision of Roux-en-Y gastroenterostomy stoma ulcer and the radioanastomosis. Our case is a 40-year-old female who has undergone excision of chronic stoma ulcer at a gastroenterostomy site. This is on a background history of revisional Roux-en-Y gastric bypass 6 months ago and previous history of sleeve gastrectomy 10 years ago. Pathophysiology of her stoma ulcer was likely ischemic in nature, with smoking as a contributing factor. Following the Roux-en-Y gastric bypass, the patient was slow to recover and had persistent epigastric pain, bloating, as well as anorexia over the course of 6 months. 2 gastroscopies were performed, one in January 2020 and a repeat in March 2020, demonstrating persisting gastroenterostomy stomal ulcers, despite her being treated with high-dose PPIs as well as sucralfate. She was also advised to stop smoking. Following discussion with the patient, the decision was made together for revisional surgery. The surgical setup for this operation involves the use of 3 5mm ports along with a 15mm stapling port. The diagram demonstrates the positioning of the ports along with the Nathanson retractor. Upon entry into the abdomen, there were significant adhesions relating to the gastric pouch onto the left side of the liver, which required dissecting. The next step of the operation was to define the points of transection of the gastric pouch as well as the alimentary limb in order to resect the disease anastomosis. Initial dissection was performed on the left as well as the right side of the pouch to free up adhesions that fixed the pouch to surrounding structures. A tunnel was created posteriorly, allowing for stapling of the pouch. The proximal alimentary limb was first disconnected using a EndoGIA 10 60mm stapler. Next, the diseased gastroenterostomy was excised with an initial firing of the EndoGIA stapler with a 60mm black reload to disconnect the pouch at the site of transection. Refashioning of the gastroenterostomy was performed using a hands-on laparoscopic technique with 2 layers of posterior suture along with a single layer of anterior. The initial line of suture encompasses the small bowel and oversews the staple line of the gastric pouch. A gastrostomy as well as enterostomy is formed. Next, 2O monochrome V-lock was utilized to close the posterior wall as a second posterior layer, taking seromuscular bite. This suture was then turned anteriorly with a second 2O monochrome V-lock starting on the left lateral aspect and then making its way across to the right side of the anastomosis, closing the anterior defect/wall. To end, the two V-locks were lined up and a single intracorporeal tie was placed prior to locking the suture for completion. On our most recent follow-up at 1 month following her surgery, the patient is doing well clinically and has had resolution of her previous symptoms. She has also managed to lose weight and is currently at 80 kilograms.
So we're going to present a type of treatment to manage sleeve leaks. So the patient received sleeve gastrectomy, a male patient with BMI 37, age 30 without diabetes, and we already reinforced the staple line using seromuscular suturing. The patient was discharged at POD2 following normal upper GI series. Now at POD7, the patient was readmitted with complaint of fever and abdominal pain. At this time, we suspect leak, but we only give a conservative treatment. But at POD10, the patient condition went severe, and we performed emergency surgery. So our technique was actually a slight modification from Professor Lee's method, where he performed laparoscopic and endoscopic procedure. So in this video, we can see the inflamed and infected abdomen. We can see the pus. And for the first procedure, we're going to insert the jejunal feeding tube into the jejunum. The jejunum was located at about 30 centimeters from the tricep ligament. And then we fix the jejunal feeding tube to the jejunum. And for the next step, we're going to insert the bougie tube and the NG tube. And we're going to use the help of the bougie tube to place the NG tube to the proximal end of the stomach. We already make a small incision near the tip of the bougie tube so that we can insert the NG tube. And then we just pull the bougie tube outwards to easily place the NG tube near the proximal end of the stomach. And then when the bougie tube reaches at about 35 centimeters, we separate both of the tube. Just by pulling out the bougie tube while gripping hard the NG tube, we can easily separate them. And then we just fix the NG tube to the stomach. And following this, we place 4 at the abdominal drains, 2 in the pelvic area, 1 in the splenic area, and 1 near the stomach. And then the last step is just to fix again the jejunal feeding tube. So the operation takes about 4 hours. There's total 6 drains, and we perform a leak test, but unfortunately we cannot find an obvious source of the leak. Now the patient was discharged at POD 17. We already removed 3 of the abdominal drain, so there's only 1 left. And as you can see that the patient condition went normal. Now at POD 33, the patient has no complaint, there's no fever or abdominal pain. The patient can ingest water, but the nutrition is still through the jejunal feeding tube, and we continue observation. And following discharge, and actually at POD 51, we remove all the drains. But before that, about 1 week before that, we asked the patient to have fluid diet to see if there's any discomfort, but the patient is okay, there's no discomfort. And at POD 51, we remove all the drains, and the patient can have fluid diet without discomfort. So at this time, actually, we can judge that the leaks has already healed, and this procedure we can say that it's safe and has a good effect. Thank you.
Hello. A 36-year-old obese patient came to the ER 2 weeks after laparoscopic gastric bypass with the signs and symptoms of intestinal obstruction. We took abdominal x-rays and we saw that the remnant stomach is filled with air. So we decided to take the patient to the OR for a diagnostic laparoscopy. You can see the gastric remnant here. It's very, very distended. So first we decided to decompress the gastric remnant to lessen the pressure on the gastrojejunectomy and also to lessen the chance of spillage of the fluid inside the stomach, inside the obstructed intestine to the abdominal cavity. You can see the gastrojejunectomy here. Then we close the gastrotomy with a tan stapler. After that, we started to do an intestinal walk from ligament of Troit's, and you can see that the biliopancreatic limb is fully distended, and the obstruction is here at the JJ anastomosis. You can see the adhesions here at the site of closure of the JJ defect, mesodefect. We try to release these adhesions by sharp dissection. Also, you can see that the root limb is not distended. This is the adhesion between the colon and the JJ anastomosis. We release that. Now you can see the adhesions between the common channel and the end of the root limb at the JJ anastomosis. They are not distended. We try to release the adhesions here too, in order to prevent any other obstruction in the future. We use suction dissection together with the sharp dissection by scissors. Then to correct the obstruction at the end of biliopancreatic limb, we decided to widen the JJ anastomosis by firing a new stapler from the left side, not from the right side, between the biliopancreatic limb and the common channel. We filled the stenosis when we were firing the stapler. After that, we tried to close the site of enterotomy. You can see somebody is using the suction to control the spillage of the fluid, because this fluid is filled with bacteria in an obstructed situation. After closing the enterotomy site, we rigorously used saline to clean the intra-abdominal space in order to prevent the formation of any abscess. The patient did very well during the next days, and she is doing well 3 months after the surgery. Thank you.
Great. Let's bring our panel on and have a bit of a discussion. They all, as you can see, I think a lot of this type of complications can really arise in our area, because I think at the moment a lot of people doing sleeve, but more and more people doing bypass, etc. So we need to share the experience to hopefully not having anything happen to our colleague herself. So maybe I start with Professor Kosai. So I just forgot I didn't have time to say your CV, because otherwise we'll spend the rest of the night because it's too long. You've been big upper GI surgeon, and you're pretty qualified to comment on that. Any suggestion for our personal video? So, you know, I think any thought you have after seeing all this video? Are you on mute?
Can you hear me now?
Yes, we can hear you now. Thank you.
So very interesting 4 videos, which any complication videos nowadays is very, very, very useful for us surgeon, because this is where we learn from mistakes. I think, you know, 4 interesting videos. Let's start with your video, Ken. So did you do a vagotomy with it, or did you when you refashion the gastroenterostomy, did you do a vagotomy or no?
I think this person's the problem is smoking, so we tried to hammer it on. We did get the ulcer healed for a period of time, but it come back and it's giving her pain, etc. And she swears she's going to stop smoking. So I thought I'll go in first to see if there's any problems. And we're very fortunate it's only adherent to the liver, but it could be worse. And I agree that I think I actually routinely do a posterior stapler and anterior closure, and I'm wondering if there's probably an area of ischemia secondary to that rather than actually surgical technique, because Hanso is always the fallback in my view when we first started to do laparoscopic surgery. So all the surgeons need to learn Hanso before they move on to stapling to kind of speed up the procedure, because speed is not essential here. You know, it's the long-term results is more essential. Yeah, no, we didn't do the vagotomy. That's your plan. That's what I think. Probably should have, yes. Chen, you agree?
Okay.
Yeah, I do.
Mohammed, you are you're a bit you know, man in black at the moment, but we know where you are, so it's okay. Any comment on one of the experts and our videos? Have you have anything to add to it?
Yeah. Hello, all of my friends. This is really very interesting panel, and I'm enjoying to be here. I have a lot of questions. Fortunately, now is at noon, and unfortunately, the background is too much bright, and my feature maybe is dark. But my question about the first video, which my dear friend performs about when you remove about 1 meter of small intestine due to gangrenes, why you do not change the operation to normal? Because actually removal of about 1 meter of jejunum is very important operation for morbid obesity. And in this case, which we have removed about 1 meter of the small intestine, why we try to remain the gastric bypass in the case?
I think I'll take this question, Professor Mohammed, because this is my video. Salams, and great to see all of you guys again. Well, like I said, the safest thing in a complication in bariatric surgery is to first salvage, right? This patient was in septic shock. Again, like I said, this patient also had COVID at that point of time. I didn't want to take any further chances of deterioration. So I said, let me go and reverse it, because a gastrogastrostomy is far, far easier in anastomosis to handle than remeasuring the entire small bowel, realigning, first doing a common channel, then again re-anastomosing the bowel and remeasuring everything. That would have been around 3 or 4 anastomoses. This was just one anastomosis. I wanted to come out as soon as possible. And then maybe when this whole pandemic gets over, if the patient gains weight, I think I can relook at it from that point of view. Ken, you were witness to one of the first videos I'd done in ASMBS. This is another one. We've now done 4 of these through the ring. And so the ring is a theoretical site for herniation, which so far we've never ever mentioned about.
Yeah, no, I selected this, I think, particularly for that reason. The ring does give durable results, but we also had one case similar to you, but fortunately discovered early. So we're able to pull back the bowel and remove the ring without cutting any bowel. So that was lucky. But the ring is supposed to be benign, but can be deleterious. So if the patients had a ring, if they have symptoms, you've got to get onto it. And I guess the common theme of this thing is we rather have a live patients. We go there to do emergency surgery. We salvage whatever you can, and we get out to have a live patients to improve it. I have a question for Jason, because I saw that video. It's pretty hardcore, a lot of drains, which is very good because the damage control is about draining sepsis and things. But I would think that maybe going in at day 7 when the patient presented, you may have more space and less swelling abdomen, because with complication, happening with sepsis, you are fighting against patients with deteriorating anesthetic conditions and also space issue. We never regret taking a patient earlier if we smell any trouble. So, I mean, that might be my only thought, but is the patient probably lose a lot of weight now, I think?
Yeah, the patient is now healthy, but that is our regret actually. Now, fortunately, we do not have a lot of case of leak, so there is a good thing. But unfortunately, we are not that experienced in handling this kind of cases. We actually regret, because when the patient had that symptoms of abdominal pain, at that time we should actually go through with the surgery. But yeah, that's sort of the case.
No, I agree. In the beginning, it's very confusing, and the tendency to it is to delay dealing with it. But we found that in our experience, the earlier you deal with it, even if the patient have a negative laparoscopy without any problem, you'll sleep better. And you know that maybe already day 7, the fat pad already sealing it up, and all you need to do is fast the patient for a little while and give them fluid, and they probably give them antibiotics. They may get away without any intervention, or just endoscopic, intervention would be great. I had a question for Saeed as well. I guess when you're doing it, your plan was to decompress the distended loop and find another way to deal with it. Do you think with the adhesion, it looks like there's V-lock suture there. Do you think the closure of the that space or the herniation space causes the obstructions?
Thank you. Can you hear me?
Yes, we can.
Actually, the video I presented here, it was not the starting point. Before we go to the stomach, we went through the JJ defect. We saw that, we knew that this is the obstruction at the end of biliopancreatic limb. You saw that there was adhesions at the JJ meso defect. It was a normal Prolin stitch, not the braided ones. But we knew that there was something bad at the end of the biliopancreatic limb. And we knew that we want to widen it before we go to the stomach.
Thank you. Mufi, you saw the video. Have you got any comment? I think with bypass and things, these things can happen with bowel obstruction, isn't it?
Yes, I believe that any kind of obstruction can happen once you've done even a Roux-en-Y, or for example, even an OAGB, you can get adhesive bands which can cause these severe adhesions. And I think what you did was quite correct. You made sure that you removed all the adhesions and took whatever chance there was, because you were lucky that this adhesion didn't happen earlier, become more severe, and cause a problem with your anastomosis proximally. And sometimes that can happen as well. But any kind of chronic abdominal pain, we've all understood, has to be done and dealt with a diagnostic laparoscopy, because the current modalities that we have, from a CT scan to an MR to any endoscopy, cannot pick up these kind of obstruction other than mild dilatation here and there, which can always happen with adaptation of the bowel. So you can't really make out on any other modality. So I think a diagnostic laparoscopy is warranted if a patient presents with continuous chronic abdominal pain post any kind of bariatric surgery.
That's a good takeaway point. I think the only thing you will find nothing, which I've encountered 2 times, is interception. So they had pain, and then the interception gone away. You've gone in there, everything looks beautiful. But when you have to catch it red-handed, you know, on a scan or something, and often happen actually distal to the Roux-en-Y bypass for some reasons. I think there has been a few reported cases for that. But bypass, not benign. There's a lot of traps on that, and we're kind of almost over the curve in terms of sleeve, and now we're dealing with all kind of different bypass. So this is a good starting point. Any other comment the panelists or the people who do the video want to make before we close off the night?
Can I ask a question? Can I ask a question?
Yes.
I want to ask Said about his videos, which was very nice. What do you think about the reason of this accident?
Sorry about that. About what?
You mean the reason for the
I didn't get it. Sorry. The reason.
Mohammed, you mean the reason for the obstruction, is it? Or?
Yeah, what's the reason?
Yeah, I don't know. Actually, I had done more than 1,500 Roux-en-Ys, and this patient was my own team anesthetist. The first one, I don't know. I don't know.
It's always happened to be someone important, isn't it? It's always anesthetist in my hands. Wow. Okay. So yes, that you have to be one short now. Professor Kosai, have you got any other comment for our panelists and suggestions? And in Malaysia, I think a lot of diabetic patients, and I'm presume that the go-to places now, not just sleeve, and I'm pretty sure a lot of bypass being done. So you must have seen a lot of different problems as well.
Yeah, we've done close to 2,000 in Malaysia in our institution. But I agree with Said. I mean, he's done 1,500 Roux-en-Y gastric bypass, and yet he don't know the etiology behind why the obstruction is. So I believe that nowadays all these operations are very safe, in good hands. And if you get complications, they're very unlucky. I think the patient is just very unlucky, because sometimes you just can't explain why these complications happens, especially leaks. But talking about leaks, Dr. Cheng, sorry, not Dr. Cheng, it's Jason, isn't it? Jason, yeah. Your video with the multiple drains. So I mean, you mentioned that leak is very rare at your institution, but in the future, if the same leak problem occurs, would you change your management? I mean, obviously, it looks very, the patient's abdomen looks very, very busy. I cannot disagree, I mean, with your management, because the outcome is the most important, you know, testimony to your decision to make that management. But in the future, would you consider just scope them and identify a leak, or if you can't see a leak, you would consider putting a mega stent, or, you know, something like that?
The problem is we do not have that kind of this endoscopic tools to manage it. I mean the doctors to perform it, but we like this procedure, because I think the most important is to to reduce the pressure of the sleeve itself. And our first case of leaks, we just put the NG tube through the nose, and the patient in just 2 days felt uncomfortable. So the patient just removed it, and in the end, we had to convert to bypass. But in this treatment, I think we can reduce the pressure nicely, and the patient feels comfortable, at least when you compare to putting the NG tube through the nose.
Sorry, I actually been ignoring my phone. There's actually two questions from the floor. So the first questions they have is, do arrhythmia occur during gastro or endoscopic surgery, and what kind? Have you ever lost a patient without cardiac disease for heart block during gastro endoscopic surgery? And that's by a cardiologist. I'm very impressed about our physician actually taking notice of what we do. I think, I mean, I guess cardiac surgery, cardiac is actually a side effect of metabolic problem as well, but heart block and etc. Is a little bit rare. Anyone have any experience or any comment on that? I personally haven't encountered it yet, but it may come. Mufi?
I think what we need to be careful of, Ken, is sometimes some of the anesthesia drugs can interact with some of the antipsychotic drugs that a lot of these patients are taking. So just be careful on that front. Otherwise, I think any patient with a known electrophysiological anomaly like an SVT or an atrial fibrillation, I think needs to be sorted out way before. All precautions need to be taken before you take him off surgery. I think that's the only other precaution. Once a patient's on antipsychotic drugs, please ask your anesthetist to look at what drugs they're giving him so that there's no interaction between these drugs.
And the SGLT as well. I think from the last sessions, a few of the patients with that come back in a week afterwards that we thought is surgical problem end up to be SGLT issues. So the diabetic problems can cause diabetic ketoacidosis afterwards. So the second question apparently is regarding of the closed loop obstruction clip with distended remnant. Your anastomosis, the common channel to the BP limb. How did you know the elementary limb was the patent at the GJ? The A, B, C limb meet at the JJ anastomosis. I think that's for Saeed. Yeah.
That's a very good question, very good point. We spend a lot of time to figure out it. We have had thoughts of it at the operation, but if you look at the remnant, it was very distended. If there was any obstruction at the JJ to the roof limb, you would have a very distended or leaked pouch as well. But you saw that the pouch and the roof limb, they were okay, they were normal in shape. And this was first. Second, I used the stapler from the left side, not from the right side, in order not to compromising this anastomotic side, in order not to making another obstruction at the JJ side. I go far from the first side of intraotomy to make it wide and not make it compromised by another stricture at the previous side of anastomosis.
Great, yeah.
Can I ask a question to Dr. Chen?
Yep, Mohammed.
Hello? Yes, I think that your anastomosis was very too much small, maybe about 1.5 centimeter. Is what really due to marginal ulcer which the patient had before, or routinely you do pouch anastomosis to jejunum by about very like this small anastomosis?
Thank you for the question. I think the size of the anastomosis on the video may look small, but actually it's the same size as the bougie, which is a 36 French. Ideally, like you try to keep these anastomoses that kind of size because it also adds another layer of I guess, restriction in this patient who initially had the Roux-en-Y gastric bypass for weight gain. Yeah, so routinely we do it of that size.
I guess my comment is that I've learned this from Calvin Heeger, and I think also one of the other American guys, and they are really big into smaller anastomosis at the beginning with acceptance of some stricture rate. because the long-term problems with bypass is dilatations leading towards food going through and then weight regain, etc. So it seems to be durable to have a smaller anastomosis. That's the other comment. But yes, I think hopefully Hanso will reduce the amount of ischemia or ulceration again. And we scope these patients afterwards, there's no ulcers. I think it's about 6 months now. So Mark just scoped it. So it's very good. So yes, I do agree it looks small, but that's the standard of 36 French anastomosis for Hanso. It's about 3 or 4 sutures only. Now I think we have a poll. It doesn't mean that whoever win is the best video. Then we're going to ask the audience which video they think is probably the most educational or dramatic or whatever they are. But whoever win, maybe next year in Colombo, I'll show you our drinks. I think that's all. So, and we make sure that next year we have a lot more video session, because I think it's quite beneficial. You can see the amount of question generated through here, and all of us have done a lot of surgery, and we're here to share the difficult one, not the easy one, which is the one that usually costs you most of the nightmare. And we don't want that. We want a smooth rising for especially the younger surgeons. So it's good to watch how the other surgeons deal with the problems and learn from it. So for the video, we have a vote, and then we can relax a little bit. I think the following is we're closing it, and Kazu will make a closing remark, because with these 2 days, we have to really thank our sponsors and also our executive team who put all this together, and it's fantastic. So what's the results? Oh, it's really close. That is, we got a tie. So God, I have to buy 2 drinks. I'm going to be full. Anyway, thank you very much all, and I think we'll see you next year in real time. Okay, thank you.
Hello. So I really appreciate all of you, all the participants and the speakers, panelists and the moderators and the staff, and also the sponsors for this Congress. So before moving to the closing remark of CC1, he is a president-elect, and he will take me over at next year. And but he really supports me a lot. And before that, I would like to introduce Dr. Tejana. He's the Congress President of the next Ifso Apc, November next year in Sri Lanka. And he will talk about the reason why you must visit the beautiful Sri Lanka next year. So please start your presentation, Tejana. We have to postpone the meeting this year, but Sri Lanka is a very beautiful place to visit, and also that our real meeting will be held there next year, so that it is very, very nice to hear about Sri Lanka next year. I hope his presentation works.
Yeah, Kazu, I seem to be having a little problem with my presentation getting launched. Just give me a second.
Okay, try it again. Doesn't open. Actually, today and yesterday, we are supposed to hold a meeting in Sri Lanka. And this is the same day that this virtual meeting, exactly the same day, we are supposed to hold the real meeting. To tell the truth, I've never been to Sri Lanka, so I was really looking forward to visit Sri Lanka this year. But because of COVID-19, so none of us can travel overseas. So that, yeah, we hope that next year will be the one to travel and see each other. We cannot.
Yeah. I think I will have to log out and then come back. Kazu.
Okay, go ahead. Try as soon as possible. So that now we are waiting for the Tejana login again. So sorry for the bit of delay, because that we have very hot discussion tonight. So that the program has a little bit of delay, but I hope you could enjoy our discussion. And during waiting for him, I would like to introduce the president-elect, CC1, and he will have a closing remark of this Congress, because he will take me over next year, not this year, next year. He will be the president of our Ifso Apc. So trying to kill some time, so that I would like to CC1 to talk something. CC,
okay.
Please say hi to you guys.
Thank you. Good evening, everyone. I'm CC1 from China. After 2 days of intense and warm online meeting, we have successfully completed all the agenda of this meeting, and this meeting has been successfully concluded. Congratulations to the Ifso Apc Virtual Congress on this completed success. Congratulations to Kazu Kasama. The content of this conference was very rich, including the history, present, and future of Ifso and Ifso Apc, new technique of bariatric surgery, COVID-19, and obesity, bariatric endoscopy, revisional surgery, East meet West in bariatric surgery, nutrition, surgical communication, video, essentially. 2 special lectures were also set up in this conference, including Kawamura lecture and Skopner lecture. There also have 2 satellite symposium. So this conference is very, very rich. We all know this year is a very special year in the face of COVID-19. We have not been together for nearly 1 year to attend the academic conference. However, the virtual conference has made up for some shortcomings in this regard. This meeting discussed all aspects of obesity and metabolic surgery in an all-round way, which enabled us to have a deeper understanding of obesity and metabolic surgery, and to better provide a high-quality diagnosis and treatment for all obese patients. Thank you, Dr. Kazu Kasama, President of Ifso Apc and the President of this Congress. Thank you to the conference organizing committee, Kin, Murphy, Ninian, Harry, Vijay, Jiang, Ashing, Chui. Thank you for Ifso headquarters, Manila, and MCM staff for their hard work. Thank you to all speakers, the moderators, and the panelists for your excellent content. Thank you to the 1,351 bariatric surgery professionals who registered to attend this conference. You have made this meeting more exciting. Finally, I would like to thank all sponsors. Without your support, the conference would not have gone smoothly. Thank you. I hope the epidemic will be over as soon as possible, and everything will return to normal. We can meet face to face at an earlier date. I hope we can get together in beautiful Sri Lanka on time next year. Thank you all again, and wish you all the best. See you later. Thank you, Kazu.
Thank you, CC, for the closing remark before the introduction of Sri Lanka. So that now Tejana is trying to log in, and I hope he can, and also that I hope the next meeting of Ifso Apc will be very held in Sri Lanka. And so that as I said in the opening remarks, and also the CC1 said that it's very important to establish our own evidence. So because that Asian, the patient is a little bit different from the Western, but we just have a Western evidence, not a huge high level. I mean, not a high level of Asian evidence. So that so I would like to echo the words that we need the Asian evidence, and we should do bariatric metabolic surgery for Asian Pacific patient by Asian Pacific surgeons with Asian Pacific evidence. Okay, sorry that Tejana cannot open his slide. And actually that yesterday he could open his slide and have the rehearsal or presentation. But yeah, now he can, so that I want you, all of you, to come to Sri Lanka next year and enjoy the beauty of Sri Lanka, the real beauty of Sri Lanka, not a slide of that. So I hope see you all Sri Lanka again. Thank you very much, and take care and stay safe. Bye all.
Thank you.
Bye. See you.